This session is about glomerulonephritis and dialysis. And the chair of today's session is Dr. Rose Muhindo. Dr. Rose Muhindo is a consultant nephrologist with Mbarara Regional Referral Hospital, an educator, former chair, internal medicine, and her research focus is on renal biopsies. Very soon we shall start sending her renal biopsies in Mbarara, so members prepare the patients. She will co-chair with Dr. Chaze. Dr. Chaze is a senior resident with Makerere University. So I'd like to invite the chairs to take us through the first session.
Thank you very much, Sally. Good morning once again. I hope we are ready and ready to listen. We are having a very interesting session. We have quite a number of talks lined up, and I request that you keep your ears open, eyes open. Yesterday, we learned a lot, and I know that today we are going to learn even more. I believe that GN and dialysis are very interesting topics. And I know that our presenters today are going to add or teach us more. So we have a number of presentations today, and I have the pleasure to introduce our first presenter, who is our Dr. Anthony Bate, a very, I think we all know him. I don't really need to take us through the introduction. He's a pediatric nephrologist. He's done a lot of work. He's very passionate about research. And he's also a good teacher, a mentor. And those of you who have worked with him know what I'm talking about. So he's going to tell us about minimal change disease in children. Dr. Bate, over to you.
Thank you, Dr. Rose. That microphone kept on breaking.
It didn't break when I was talking.
It fears you.
Yeah.
But I heard it.
I know.
Thank you very much, and good morning, everyone. Happy to be here again and talking about minimal change disease in children, not in adults. In any case, it's more common in children. So minimal change disease, the term is surprising because it's interesting. Minimal change disease is actually a cause of nephrotic syndrome. And it is our commonest cause of nephrotic syndrome. And for nephrotic syndrome, these are the children who come into our care because they have either low protein, proteinuria. Let's start with proteinuria. They have not either. They have one of the issues is proteinuria, which is more than 3 grams in 24 hours, although that term, we tend to leave it for adults because it's hard for us to say we've collected urine of a child over 24 hours. For children, we are either using a spot urine sample, and for those who can do protein creatinine ratio, are the ones that can now clarify it as either 2,000 milligrams per gram, or 2 milligrams per milligram, or 200 milligrams per millimole. But even without those fancy words, we can say if the dipstick is 3+ and above. So that's the quickest way to tell. Nephrotic syndrome, one, having proteinuria on dipstick of 3+, then low albumin levels, especially if we can do the liver function tests, and when the child is swollen. So that's nephrotic syndrome. So since the topic was minimal change disease, not nephrotic syndrome, I had to look for any data related to minimal change disease. There is a review which we did with quite a number of nephrologists in Africa under the H3 Africa group. And in this review, it was reviewing every study so far published in Africa, and for those where they have done biopsies, how many children actually have minimal change disease. From those studies, you can tell minimal change disease is 38%. And the other causes of nephrotic syndrome, the second commonest one, is FSGS. But remember, the only children that are usually biopsied are the ones who either have steroid resistance or have challenges. So it means much of the minimal change disease, we never do the biopsy, so we never confirm it, and it's probably among those that never even get the biopsy. But you can see even when you have made a decision to do a biopsy, still minimal change disease is high up on the list. And one of the things that we always struggle with, or that we always start with, just like I did, is in defining nephrotic syndrome. And after defining, because it's actually what guides us in the care and how we treat. But in the past few years, what is happening are the definitions that are changing so much. I think there's been an awakening of nephrology, and especially in the pediatrics world. Previously, we would just go to Nelson and have the definition as one. But currently, there are quite a number of definitions, and they keep changing. I think 2 years ago, we had a consensus group of nephrologists in Africa, and we came up with what we called the Ibadan consensus guidelines or statement. And this was because there were many statements. There was KEDAIGO 2012, there was IPNA a few years before, and people were all doing their own things. Now, immediately after, last year, 2023, no, last year was 2024, but in 2023, then IPNA came up with some recommendations on the management of steroid-resistant nephrotic syndrome. Then IPNA came up with guidelines on how to manage nephrotic syndrome. Then recently, KEDAIGO has also come up with KEDAIGO GN, a new guideline. I think that's 2022. And all of them have a few changes among them. And then you have your textbook. So when we are teaching, then the students are quoting for you the textbook. But Nelson is saying this. The new version of this is saying this. That makes a bit of challenges. But I will go through a few definitions, especially because nephrotic syndrome is about definitions, and treatment is based on those definitions. And when we do that, that's how we manage. So apart from defining nephrotic syndrome, I will just say these are the definitions that keep changing. Everyone keeps touching. And they're the ones that I've said keep telling us how we manage children with minimal change disease or nephrotic syndrome. I'm focusing on, and I'm keeping on writing the word children, because for adults, I don't want to talk much about them when the adult nephrologists are around. They'll tell me, but that we don't do. So, one is when do we say a child with nephrotic syndrome has recovered? And that one everyone really agrees. That if every time, when you're treating, since we have the doctors also here, when you're treating nephrotic syndrome, the moment on 3 consecutive days, there is no protein in urine, then that's remission. That's when we say proteinuria has gone. But some children have partial remissions. Interestingly, many times partial remissions on all guidelines are being defined based on protein creatinine, urine protein to creatinine ratio. But essentially it means sometimes you treat children and they are 3+, and they keep being 2+, 1+, 2+, 1+. That's the partial remission. The second part is relapse. KEDAIGO 2023, even 2012, kept on defining relapse as a 3+. But what is strange is sometimes there are children and they come in our clinics because we see them once. You make an appointment every Monday and the protein is 2+. Should you treat that as a relapse or not? And this is one of the things that made us in the Ibadan consensus guidelines to say, let us define a relapse as 2+. but KabiraCountry has defined it as 3+. So I think you can use any, especially depending on how much you're monitoring. But I think defining it as a 2+ is a fair statement. Instead of sending this patient away, the disease has not come back because protein is still little. I think it's safer. You define it at a lower rate, restart the steroids. Then steroid-sensitive nephrotic syndrome. So usually whenever a child is responding to prednisolone by 4 weeks, we are sure it's steroid-sensitive nephrotic syndrome, and that's the definition that we use. And if it's infrequently relapsing, if there are less than 2 episodes in 6 months or less than 3 in a period of 1 year, then we say that is infrequently relapsing nephrotic syndrome. IPNA 2023 said, I think it wrote something different there, but I think it wasn't. This is a better definition. It said, I think, less than 3 in 1 year, which I think was a bit strange. I didn't even put it there. But I think it's really an infrequent relapse if it's less than 4, which has always been the definition. And then frequent relapsing being 4 or more episodes in 1 year. Then those who are steroid-dependent nephrotic syndrome, so they are children who we treat, and every time, or even when they are still on the 2 milligram per kilogram, proteinuria comes back. Those we call them steroid-dependent nephrotic syndrome. These definitions are important because then we need to do something else. And then there are those when we've just stopped the medicine, within 2 weeks, proteinuria comes back. Those we call them steroid-dependent nephrotic syndrome. And I think the IPNA, but I don't know who changed it. IPNA and KabiraCountry one used 14, another and 15 days. I think that was a bit for fancy thing, but I think it's the same. The other catch is the steroid resistance. Steroid-resistant nephrotic syndrome. When should we say this child is not responding to prednisolone? Now, KabiraCountry says if you've treated for 4 weeks, so if you give a child prednisolone for 4 weeks and the proteinuria is still there, this is the newer guideline. Say they are resistant. IPNA has moved it to 6 weeks. It says give another room for 6 weeks to say resistant. When we were discussing as nephrologists the PID ones and that consensus guidelines, we said 8 weeks. Usually I say, therefore, this one used based on resources. I think what is guiding this is resources. When you are in a resource-rich environment, or you're with a resource-rich patient, if 4 weeks have passed, and the child is not responding, this is when you should start telling them, I think let's plan for biopsy, let's do C3, let's do ANA, let's do complement, and start investigations. If it is moderate, then sometimes people are hesitant, then you give them the 6 weeks. All that takes up the 6 weeks, the 2 weeks decision. But there is when we are in a resource-limited setting, which you all know where we practice from. You quickly worry and hurry this mother, go and do these tests. They even say, no, now I'm no longer coming back to Mulago. Those people, they think they're asking, they even want to take away a piece of my kidney from the child. Then maybe you better wait for the 8 weeks. Wait for 8 weeks. In any case, sometimes it means changing medicines. It means going to tacrolimus. It means going to mycophenolate. These are expensive drugs. So instead, if you're in a resource, when the patient can afford, changing to tacrolimus at 4 weeks or at 6 weeks, sometimes people have insurance, they even want to jump out to go to Kenya. They are asking you, doctor, why isn't the child recovering? Should I go to India or I wait for you? I think those use the KabiraCountry definition, intervene early. But those where if you write tacrolimus, you're going to make the mother even lose the transport to come back for next review. You're okay, I think, waiting for 8 weeks. Because some children are what we call late responders. Some people will respond to prednisolone, but after some time. So don't rush. when you don't have to rush. When you have to rush, you are covered. When you don't have to rush, you're covered. I think that's why I like this definition. The problem is in the exams when we ask that question. I don't know sometimes these days what answer to mark. But so the late responders is by 6 weeks. Then some people, we start them on calcineurin inhibitors, tacrolimus or cyclosporins, but many times it's tacrolimus. We shouldn't worry until it's about 6 weeks, 6 months. Because we only say you're resistant or you have partial remission after at least 6 months. So usually, like I've said, steroid-resistant nephrotic syndrome. Now you start tacrolimus, this expensive drug, and the people are asking you, but the child is still not getting better. What is the problem? Should we change drugs? Should we move out? Should we? Then they sometimes even move around. They ask the other one, ask the other. You just have to tell them, tacrolimus takes time. So we only say it has not worked after 6 weeks, 6 months. And whenever possible, we can do the tacrolimus levels. And then it's sometimes we've had to add tacrolimus plus mycophenolate. For those when you start adding more than one drug, still keep calm until at least a year. Because we only say you're multi-drug resistant after 12 months. But in any case, even if you had said it too early, what other options would you have? So I think that's why that guideline defined it that way. Because then we tied the moment there is multi-drug resistance, we just have to keep time and wait. In some places where we've been, they would even sometimes take out a kidney because it's just, you're having proteinuria, it's not controlled, it's affecting quality of life. So maybe you do partial nephrectomy to reduce. And we had that being done in places where there is transplant that is easy to access. A person or a child with nephrotic syndrome, this is some form of algorithm that is coming from KENAIGO 2023. What do we do? I want to go into the details of which medicines, but at least we know for those who are below 12 months, 12 years, we just give the prednisolone. Provided we are saying this is an initial diagnosis and we've defined it based on the first definition. Then, when we say either we've defined steroid-resistant nephrotic syndrome, that is no response, you see 4 weeks or 6 weeks, or in some cases you push to 8 weeks, right? That's when you should now start thinking of now doing more things, including a kidney biopsy, trying out calcineurin inhibitors, and adding a RAS. But I think a RAS, you can even add it early. So for those, even in our setting where we are waiting for 8 weeks, 8 weeks, don't hesitate to add an enalapril at 4 weeks. I think it is safe. Then there are those who respond quickly, and we give the prednisolone for either 4 and 4. That's 4 weeks of 2 milligrams per kilogram, then 4 weeks of 1.5 milligrams alternate day. Now in the Ibadan consensus, and many times, the shorter period of prednisolone, you have more relapses. So I think the best thing always is to give 6 weeks of 2 milligrams per kilogram, and then 1.5 milligrams alternate day for again additional 6 weeks. And then taper slowly. I think one of the things that guided the first guidelines was the Cochrane review that came out in 2006. And they realized, before that we didn't have much guidelines. They realized the longer children stayed on steroids, the longer they took to relapse. The only issue was reaching a consensus on how long to avoid the complications. But otherwise, the longer they keep on, the better. So I would really not advise the 4 weeks, but 6 weeks as the best approach. And like we already said, the definitions then define. You remember the definitions we were going through. Whether if a child is a frequent relapser, then we can add cyclophosphamide, levamisole, mycophenolate, mofetil, use of rituximab or calcineurin inhibitor, or if they're infrequent relapsers, then we just use the prednisolone. And if they are steroid dependent, now this, don't take it as it is. If they are steroid dependent and they are on a low dose, I don't know why they didn't put it there. We should keep them on the low dose. If you're dependent on 5 milligrams, we don't add these other extra drugs. If you're dependent on 10 and the child is big, sometimes I've also not added, even up to 15, because the cost of these drugs is high. But if the child is dependent on higher doses, for sure we need to add either mycophenolate, mofetil. It's rare that in steroid dependence you add rituximab, except those who are dependent at very high doses and they're not responding to mycophenolate or tacrolimus. But otherwise, these other drugs work. So, I think that's really about the management, precisely. But there are times when we do a biopsy in children with nephrotic syndrome, even when they are steroid sensitive, or we are thinking it's pure minimal change disease. So sometimes if they are responding late and they maybe require a lot of steroids, you may decide to do a biopsy. Or a high index of suspicion for other underlying pathologies, when you want to see if they have calcineurin inhibitors affecting their kidneys or they are steroid resistant. Now on biopsies, I just have a statement on them. Immunofluorescence now, it used to be a problem of mine, so sometimes I had to send patients to Kenya, then they do immunofluorescence. There is a lab there in Mulago, now we are able to do immunofluorescence. They take the tissue to India. Thank you. They take the tissue to India and they do for you immunofluorescence. So there is no more reason to do a biopsy, especially in glomerulonephritis. I think that's Dr. Chigundu who is going to discuss glomerulonephritis. And you need to diagnose IgA nephropathy, which is our common cause of glomerulonephritis in children. And then you just do light microscopy. I think it would be when there is really resource limitation, but because the biopsy is done once, I think we should use that lab. I don't know its name, but I know the contact. It's called Star Lab, or Modern Lab. But they have been taking my tissues. It's not campaigning for them. So complications you should look out for. One of these, you can see, this was actually an M-Med student. Complications, she found out that our prednisolone affects the eyes. It was quite an interesting thing. And so we should also evaluate their eyes. She found quite a number of complications, which we never look for. But I think some children of nephrotic syndrome get these complications. And last month, is it last week, again, this is one of the students I was also supervising. And she also realized our children are stunted. Our children are not growing. I know in Canada, that was a very big thing. We would be giving growth hormone. We had the charts and you think, why are they? But they were giving all those hormones to make sure the child keeps up with height. But I think for us, we won't be able to do that. I don't even know what we can do different. Because surprisingly, what she found when she was studying is that the older children are shorter, but also those who have either steroid-resistant nephrotic syndrome or the ones who have been longer on steroids. And the reasons for steroids is because we need them. First of all, they can't afford tacrolimus or other drugs. So it's really a big challenge. And the children were obese. I didn't present that. They were big but short. So we didn't have anyone wasted. It's a challenge, but I don't think we have much we can do. But we look out for other complications whenever we are treating our children with nephrotic syndrome. We should evaluate for infections because they sometimes keep getting sick, especially when they are resistant and we're on steroids for longer, or we have added another drug like mycophenolate on the steroids, then they keep getting infections. Still the same cardiovascular complications. including hyperlipidemia. We don't use statins, so if you ever look at our prescriptions, you won't see the statins. I don't know, I think we don't have studies that tell us strongly that these will be helpful. And also we have the feeling that if, except in steroid-resistant nephrotic syndrome, many times they recover. They recover quickly and everything resolves. So we tend not to put, but for adults, they use them. And for very good reasons. I think adults have more problems than our children. But for us, we don't have any studies that tell us whether statins are important and how they affect long-term outcomes. But they can get other respiratory problems, either effusions, embolism from the clotting because they lose antithrombin and protein C in the urine, and venous thrombosis. A child who is steroid resistant, if they come with bleeding, hematuria, which is macroscopic, sometimes it's the renal vein that has clotted. So we need to think through that. And sometimes they get AKI from Lasix. They get AKI from Lasix, and a few convulse. So when we are restricting sodium in children with AKI or even in nephrotic syndrome, we should always be thinking about the hyponatremia. Hyponatremia is a common complication of nephrotic syndrome, especially because as they lose fluid, desmopressin rises. Desmopressin will activate aquaporin receptors, not the RAS receptors. Because here we are not dealing with RAS, we deal with more thirst. And so they generally have hyponatremia. So if you give long doses of Lasix, sometimes they convulse because of hyponatremia. And then you've told them, restrict the sodium. Don't take salt, don't chase salt too fast. The whole idea why we don't want salt in children, on my last slide, the only reason why we don't want salt in children with nephrotic syndrome is not because it causes problems. The reason is, if you took popcorn, it has salt. You can never take it without water. So if I take popcorn or nuts that are salty, I will be very thirsty, so I'll need to drink. So therefore, to avoid drinking a lot of water, we avoid those high salty foods. But we don't completely eliminate salt. Moreover, if you have AKI or CKD and you eliminate salt, the children will waste because they will refuse food. So otherwise, there are many other complications which may be treatment related, which we need to take to think about. But as I finalize, one, the topic I was told was minimal change disease, and it's the commonest cause of nephrotic syndrome in children, and most children will be between 1 year and 6 years. There are different modalities and the definitions that keep changing, but those definitions are very important because they guide our care. But also, as we treat, don't forget the problems that come from the complications. Thank you very much.
Thank you very much, Dr. Bate, for that informative session on nephrotic syndrome in children. Allow me to quickly introduce our next presenter. So we shall have a small switch, and we shall jump to Mr. David Wamoto, who will be presenting about nurses' knowledge and practices regarding patient monitoring during and after dialysis. Mr. David Wamoto, I'd like to welcome you.
Good morning. You are most welcome. My name is David Wamoto once again, working at Judo Hospital, BSN nurse. I've also gotten a training in caring for patients undergoing hemodialysis, the Kidney Foundation. I'm grateful for that. The microphone keeps teasing me. All right. Yes, I've been caring for patients receiving hemodialysis for over 4 years in Children's National Referral Hospital, and that experience informed my study. And so here we are to share the findings I came up with. So the topic is exploring nurses' knowledge and practices regarding patient monitoring during and after hemodialysis at Children's National Referral Hospital. Why I chose Children's National Referral Hospital? One, it's my workplace. Two, it is the facility where in Uganda you afford the cheapest dialysis, but we have the highest number of patients receiving hemodialysis in Uganda. So even when we have the highest number of patients receiving hemodialysis in Uganda, that can inform us that we have the highest number of nurses who are my study participants. So a study which was done in 2022 revealed that most of the patients who are having chronic kidney disease require hemodialysis for survival. And when patients are undergoing hemodialysis, there are a lot of hemodynamic changes that happen in their life. The session may vary in duration depending on the indication for dialysis. So because of the hemodynamic changes, it needs someone besides this patient to monitor. The machine will do its role as set by the attendant, but then there is something you should do, a taker, and that is a renal nurse or the hemodialysis nurses. And then in Uganda, you realize that we have very few trained hemodialysis nurses that have the desired knowledge in hemodialysis patient care. We appreciate you. It has introduced the training for nurses caring for patients with hemodialysis, and so our numbers are increasing, but still we are still few. We have more centers with hemodialysis machines, but nurses are still few. So even when they are few, do they have the knowledge to care for these patients here? So a study done by Bagasha revealed that there was low quality of life for patients on hemodialysis at this study center. And in my 4 years of experience, I reviewed the registers in Children's Hospital, and I realized that we have 2 in 5 patients develop complications on hemodialysis. And when I reviewed the registers in September 3 to December, we had 8 deaths of our patients happening on the machines. And when you'd actually try to follow up what was the immediate cause of death, you would find that it was a sudden cardiac arrest, something maybe would have detected before it really. So I'm prompted to find out the contribution made by the nurses' knowledge and practices regarding patient monitoring to the quality of life and survival rate among the hemodialysis patients at this study site. So I have 2 questions in this study. What knowledge do nurses at Children's National Referral Hospital unit have about patient monitoring during and after hemodialysis? And how do these nurses practice patient monitoring during and after hemodialysis? The 2 questions have informed my 2 objectives, mainly wanting to explore the nurses' knowledge of patient monitoring during and after hemodialysis, but also what is the practice that's being done, because one way being knowledgeable, but also doing what you should do. So I have only 2 objectives. And the findings in this study are actually informing nursing care practices, which will definitely improve the quality of care that's being received by patients in Children's National Referral Hospital, but also extending the same knowledge to other units. And then the findings will benefit the education sector in reviewing the curriculum for training nurses, especially by UAKF. And I'm glad most of the stakeholders of this training here to hear these findings here. So the findings of the study are also to inform future research studies, and policymakers are to be informed in this gathering as well. So this is the concept framework. We have the nurses' knowledge, which we want to establish what is their level of training, their level of education. That can inform us how much they know. But then also, what do they actually monitor? The parameters. Do they monitor the vital signs, the patient's well-being for patients on hemodialysis? Do they even know the importance of monitoring patients when on hemodialysis? And then you realize that when this nurse has this knowledge, it's going to inform their practice. So a nurse who is informed, who is trained, he may have time or he will have a thought of reviewing guidelines to guide one's practice. But also, do they have what to use? Availability of equipment. Should do, but you have limitations. You know, I must do this, but I don't have this. So availability of equipment will also affect their practice, but also the challenges they face. We want to explore which challenges are those. And then, when the two are handled, when a nurse is informed and they know what they are doing, they are practicing the ideal, you'll find that the quality of life for these patients will be affected in one way or the other, which we are about to discover. And then definitely their survival rates will vary depending on the quality of life that they are having. So I did a qualitative explorative design. The site already said being Chirudu, and I used a non-probability purposive design. My sample size was chosen using purposive sampling. Why non-probability? Because I know the population I really want to interview. And then these are nurses. So purposive was really important, that it will give me the right information. So when I had data saturation, that informed my sample size. And I included all nurses working in the hemodialysis unit. These should have worked for at least 3 months in this unit here. And they should not be caring for patients receiving hemodialysis who are in ICU. Why not ICU? Because I used the same unit for pre-testing the interview guide. The findings, this collection, the data that was collected was analyzed using thematic analysis. And here are the results. I came up, I had 3 themes. Something has happened, sorry. But there are 3 themes. We have the nurses' knowledge. You realize that these nurses have different sources of knowledge regarding monitoring patients on hemodialysis. And they had different skills in patient monitoring for patients receiving hemodialysis. But also they had the understanding on the importance of monitoring patients, as well as knowing the complications that they may anticipate or their patients would suffer from. And then their practices was affected by the guidelines, which were either available or not. And in this study, we found out that guidelines are available. The KidGo guidelines are available for monitoring patients with hemodialysis. Unfortunately, the majority of the participants were not aware of these guidelines here. This study unit, the study site did not have the local guidelines, yet it is recommended in number of articles that each unit has or gets local guidelines to guide this team of care providers. And they had varied skills, yet they were doing the same thing of monitoring patients. So these competencies that they had were faced by a number of challenges. Some of the challenges were individualized, ranging from some having limited knowledge, others had this high knowledge, but then they were limited by institutional challenges that are related to lack of equipment, no guidelines to follow, such issues. So findings revealed that nurses were knowledgeable about patient monitoring, and this was consistent with other studies in the past, which revealed that hemodialysis nurses are actually knowledgeable. But there were practice gaps, and these are still consistent with a study done by Arushida in 2020, who also indicated that hemodialysis nurses in Egypt and Nepal were knowledgeable but had gaps in practicing competences. And then these gaps could actually indicate, another study indicated that hemodialysis nurses encounter challenges which compromise their role of patient monitoring. That was by NASA in 2022. And in conclusion, you realize that the nurses have the knowledge, they know what to do, and they know what may happen if I have not monitored my patient. But they are doing this practice in different ways. The recommendations are a patient should be monitored. For a stable patient, pass by, take their vital signs after every 1 hour, irrespective of whether we are doing a CRT or intermittent. But at this study site, the patient monitoring was at the discretion of the nurse. Why? Largely because of the institutional challenges, lack of equipment to use, overwhelming numbers. One of the participants that I says, I realize I need to monitor a patient in a corner. Only to reach there is no machine to use. There is no blood pressure machine. When you run on one, it has no battery. Take it, connect to that patient. When you want to place, it is actually off. You want to call someone to support you, he said, but that machine has been out of service, and I've informed the hospital administration. So what are we saying here? Well, this study was done in one site, that is Children's National Referral Hospital. But as I described my study site, most of the nurses being trained for hemodialysis management or caring for patients, it is happening in Children's National Referral Hospital. So we can largely depend on these findings to talk to the stakeholders, to support these study sites, these hemodialysis units. Can we have the equipment? Can we have nurses get continuous medical educations? Can we have in-service trainings maybe on a monthly basis to help align their practice? Because they know what they should be doing, but they're not doing it for one way or the other. If a HD unit is being started in some hospital, do you have the nurses to care for these patients? Or you want to have one nurse who is trained, and then you give this nurse over 10 patients? Do you think of what should be done? So recommendations are, for a stable patient, they should monitor their vitals after every 1 hour. For unstable patient, even you'd want to monitor this patient after every 5 minutes. But this cannot be done if you are having one nurse on your HD unit and you have 5 patients who are on the machine. A machine is a machine, it cannot monitor a patient. You need someone to stand by. I appreciate you all. I'll be glad if UAKF takes on this advocacy to ensure that all the HD units started are having the equipment, but also having the trained nurses required to deliver quality hemodialysis. And then as we are training the nurses in hemodialysis, let us give them the rightful knowledge, especially basing on the sources of information as has been outlined in this study here. Thank you so much.
Thank you very much, Mr. Omoto. Let's give him another round of applause. Thank you for that very passionate presentation. And we are glad that we get to hear the real challenges. I think your concern about the single center and non-generalizability is, I'm sure we know that if we did the same study elsewhere, we'll probably get similar results. But it's a good point, and it's really part of advocacy. And later this afternoon, we'll be discussing things like that, training and so on. Next, ladies and gentlemen, allow me to invite Emma. I'm not seeing him. I don't have my glasses. Hey, okay. Yes, so we are going to have another presentation, and it's going to be adequacy of dialysis. Still, the study site is Chirudu. I know that many times as we are dialyzing patients, we don't know if we are doing the right thing. This is one of the studies that has been done, and it will inform maybe our practices. It's the next one. But then after that presentation, the other one, the next one, the one you had projected is for the next one. Okay, sorry, we're having a few technical challenges, but we'll sort them out soon. Should I take it away?
Yes, good morning, ladies and gentlemen. Good morning, ladies and gentlemen. I hope I'm audible. Yeah, my name is Emmanuel. Some people say Engole, but where I come from, we say Engole. Engole, not Engole. Yeah, I'm also a dialysis nurse, and recently I attended a Master of Science in Clinical Epidemiology and Biostatistics at Makerere University. But before I dive into the study, allow me to recognize my supervisors for this particular study. I see Professor Kalyesubula. I haven't seen Dr. Bagasha, but she was my supervisor as well. I also haven't seen Dr. Chigundu, who played a very big role because part of the data I used in this study was the data that he used for his master's. So what I'm presenting today is these are the results from my thesis for the master's degree. We are in the process of making the manuscript, and hopefully we will publish this study. So this study was on the prevalence, healthcare workers' perspectives, and factors associated with hemodialysis adequacy among adult patients with kidney failure at Chirudu National Referral Hospital. And for the purposes of context, these are some of the operational definitions, where in this case, we considered adequacy to be a URR of at least 65%. And kidney failure was considered a GFR of less than 15, requiring kidney replacement therapy. And malnutrition, in the study that Dr. Chigund did, assessed using a dialysis malnutritional score, and any score of at least 11 and above was considered malnutrition. For the blood flow rates and dialysate flow rates, during the session, they considered the maximum. We all know that at some point, the nurses keep making the adjustments. But for the purposes of consistency, they consider the maximum flow rates. Brief introduction, globally CKD aside with an 87% rise in prevalence, and in Uganda, the prevalence is up to 15%. We all agree that HD is the most accessible form of care, and usually it's as a very complex procedure. David just said that the machines do their work, but most of the work is actually managed by the healthcare workers. And that explains why we included the component of the healthcare workers' perspectives, so that we could get the context in which they operate. However, despite the importance or the importance of HD, we realized that there had been no studies to quantify the adequacy. Yes, we probably can suspect that maybe the dialysis is not adequate by clinically looking at our patients, but we did not have on record how adequate are the sessions that we are giving our patients. And therefore, we considered, we thought that there was an urgent need for this study, and that's why we did. The general objective was to determine prevalence, explore the healthcare workers' perspectives, and the factors associated with optimal HD among those patients at Chirodo. This was a sequential explanatory mixed method study. It was sequential in the sense that the quantitative data was already collected in the study by Dr. Chigundu. But to put in the context of where these patients are dialyzed, that's why we introduced in the component of the healthcare workers. This study was done at Chirodo. David agrees with me that it's the largest unit for obvious reasons, because I think they have the cheapest HD services. At the time, they had 15 staff. I don't still the case. And they provide subsidized HD services to over 60 patients per day. Participant selection, quantitatively, we considered all the records, the primary study. Just briefly about that primary study by Dr. Chigundu. It was done in September 2022, and he was looking at the incidence and the factors associated with dialysis-related hypoglycemia. And it involved 122 adult patients with kidney failure. We calculated the sample size to achieve by power of 80% and 95% confidence interval. And for the healthcare workers, we considered those that were providing care, and we perspectively selected them with maximum variation, as you will see. But they were all required to provide informed consent, and their sample size was determined by saturation. David talked about saturation. So saturation basically is when you interview participants to a point whereby you no longer get any new information. Maybe someone out there will be asking themselves, what is saturation? That's what saturation means. So for data collection, we used the data set from Dr. Chigundu, and then we also did in-depth interviews for the qualitative data. This were done by the PI, and that was me. And we thought that we also did them in a very conducive room, which is very important for qualitative studies. You don't want interruptions. The interviews were audio recorded, and interview notes were also taken. So analysis, for the quantitative component, we used Starter 17. The numerical variables were summarized with medians and interquartile ranges. Categorical variables as percentages, and the prevalence of HDA was expressed as a percentage with its corresponding 95% confidence interval. And at multivariate analysis, we used modified PASO with robust standard errors. Modified PASO was selected because the prevalence was above 10, and we needed to use prevalence ratios to estimate the association as opposed to odds ratios. I'm a biostatistician, so you'll forgive me if I'm going so much into the statistics. Our statistical significance at this level was set at 0.05, and confounding was considered to be at least a 10% change between the crude and adjusted prevalence ratios. As for the qualitative data, we did an inductive content analysis using open code. So inductive content analysis, for inductive, you allow the data to evolve. You allow the data to bring out the themes. I think for David was deductive because he already had, I think, the themes, so he was looking at what falls under those themes. But for inductive, you allow the data to evolve. Results, just briefly about the characteristics of the participants. So for the quantitative component, their median age was 43 years, and the majority of them were male, and only about 4.1% had never been to school. Majority were employed. Minority were HIV positive. A majority, as expected, were hypertensive, up to 92.6%. Surprisingly, the diabetics were only 27.9%, and most of them, a greater percentage of 45.9% were malnourished. We know the challenges with nutrition with our patients. Like I told you, the healthcare workers were selected purposively with maximum variation, and we tried to get individuals with different working experiences, both as healthcare workers, but also as HD care nurses. For details, you'll refer to it when the slides are shared. I think I forgot to share another slide of, I think I missed it out here for the results. So the prevalence of patients who are received in this study was 48.4%. And for the factors at multivariate analysis, sex, malnutrition, blood flow rate, dial set flow rate, and dial set vintage were found to be associated with optimal HD. Brief about the discussion, the prevalence, as I said, was 48.4%, and this means that less than 5 in 10 of those patients were receiving optimal HD. Now, hemodialysis is a treatment, and I think all of us agree that every patient deserves the right or the correct dose of the treatment. So for more than half of the patients not to be getting an adequate treatment, I think should be of concern to us. This was found to be lower than a study in Mwanza, but similar to that in Khartoum and higher than the findings in Dar es Salaam. And this is possible because the study settings and study designs were different in the studies that are quoted above. But also, this HDA was measured once in this study, and probably it may not reflect the true value. So I think it's important that we maybe conduct other longitudinal studies to ascertain whether it is true, because on a day there could be other challenges. For factors, there were 5 factors. Sex was one of them. The males were 45% less likely to achieve adequate HD than females. And these findings were similarly reported in Iran. This is possible because HDA is inversely proportional to the urea volume. And we know that men are taller and have a higher volume of distribution. But during the interviews, the healthcare workers also explained that females have less muscle mass usually have lower activity and they have better diet adherence. And that could have explained why the females were more likely to have optimal HD. Malnutrition, surprisingly, the malnourished patients were 46% more likely to achieve adequate HD. And this was consistent with a Turkish study showing higher adequacy among malnourished patients. And this could have been because the malnourished patients tend to have smaller bodies and lower distribution of urea distribution volume. And healthcare workers also explained that the lower body mass, protein stores, and uremic burden contribute to this apparent adequacy. So it is apparent adequacy, but doesn't necessarily translate into the patient well-being. So you find that they could be getting an apparent adequacy, but then clinically they are deteriorating. So I think it is very important that I don't know if Chirudu now has a nutritionist, but the last time I was there was no nutritionist, which is very, very disturbing. The other factor was blood flow rate, and patients with the blood flow rate above 250 were more likely to achieve, and these findings align with an Egyptian study. And the healthcare workers confirmed this, possibly because a higher blood flow rate increases blood exposure to the dialyzer per time, and this enhances urea and toxin removal. The other factor was dialysate flow rate, where the patients with a higher dialysis flow rate were less likely to achieve HDA, and this contradicted a study in Korea. And the explanation to this was possibly because we were recording the maximum dialysate flow rate. It is possible that these flow rates could have been adjusted, or something called backfiltration could have happened. And the last factor was dialysis vintage. There were the patients with dialysis vintage of over 12 months were less likely to achieve, and no specific studies had made this association. However, the healthcare workers explained that patients on long-term HD present challenges with vascular access, declining kidney function, body composition changes, and treatment fatigue, and poor adherence. Some of these study limitations, we used secondary data, especially for the quantitative component, and data on some key variables hadn't been collected. We also had to step down on adjust on the sample size for the prevalence, and then also these study findings may not be generalizable because of the single HD unit. The overall conclusion, the overall HDA was low, and HDA was associated with the factors we've discussed. We recommend that patients should adhere to their diet and fluid restrictions, healthcare, and policymakers need to develop national dialysis guidelines considering our local context. But also we should consider doing maybe a larger study to include both the public and the private facilities, and then we compare. I acknowledge the individuals listed there. Thank you.
Thank you very much, Emma. Very eye-opening revelations here. We shall have a time to discuss these. So, allow me to introduce the next speaker. Next speaker is a classmate of mine from undergraduate, but also a resident now at Mbarara University doing internal medicine. Allow me to introduce Dr. Adolf Biamukama, who will be telling us about how adequate the hemodialysis being done at Mbarara Regional Referral Hospital is.
Thank you so much, Dr. Chaze, for that introduction. I'm humbled. Good morning, ladies and gentlemen. By the names of Adolf Yamukama, like my colleague said, from Mbarara Regional Referral Hospital and from MAST, we are privileged to present to you our results of a study that was done at Mbarara Regional Referral Hospital that we have been doing since 2024, from August now, and still collecting our data. The study has been done by Adolf Yamukama, and we have been supervised by Dr. Rose Muhindo, Dr. Conrad Muzaura, who are all faculty senior lecturers at the Department of Internal Medicine. The study was titled Prevalence and Factors Associated with Hemodialysis Adequacy at Mbarara Regional Referral Hospital. And like my colleague has said, we know that CKD is a big problem worldwide, up to 850 million people suffering from chronic kidney disease. And in sub-Saharan Africa, this accounts up to 13% of all the patients that we see. And in Uganda, like most of our colleagues have said, it ranges between 6 to 15%, and of course, depending on the population you are studying. And unfortunately, the case fatality rate tends to be high. For those who have got CKD, up to 21%. And for those who have got end-stage kidney disease, this is as high as 51%. Unfortunately, for most of the patients who come because of the limited resources and for the treatment modality that we have, for most of our patients, what we're able to offer for them is hemodialysis as a form of treatment. Of course, we know there are other things like kidney transplant, which our colleagues were talking about yesterday, and we are yet moving there. Because of the limited resources, and like for most of our colleagues have said, this is a treatment that for most of our patients pay for. And so at the end of the day, from what the DIGO recommends as 3 sessions per week, for most of our patients end up like they can only afford 2 sessions per week. And this, of course, at the end of the day is not the standard. Out of the 12 hours they are supposed to get per week, most of our patients end up getting 8 hours of dialysis per week. And at the end of the day, we think patients do not get adequate dialysis. We know that when the patient gets adequate dialysis, the adequacy of dialysis improves their quality of life. Patients, in terms of productivity, improves. But also at the end of the day, the morbidity and mortality reduces. And we know for sure that if you have got a patient who is having adequate dialysis, for every 5% increase in urea reduction ratio, you have got a reduction in mortality of up to 11%, and this has been documented from the previous studies. In our setting, especially at Mbarara Regional Referral Hospital, we still see patients who are undergoing dialysis. They are still coming in with different complaints, and so the rate of hospitalization tends to be high. They come when they have their low levels of productivity, and so the quality of life is not good. But also this is also coupled with high mortality. One of our colleagues did a study and found that at the end of 1 year, we had up to 62% mortality, and we felt this is high. Partly we think this could be because of the hemodialysis adequacy levels, whereby maybe most of our patients do not actually get the required minimum levels of hemodialysis. And so we aimed to seek out to assess the hemodialysis adequacy among our patients with chronic kidney disease who are undergoing hemodialysis as a means of treatment. This was a cross-section study, prospective. Like I said, we started in 2024 in August, and we were set out to enroll 93 patients. And we are doing this at Mbarara Regional Referral Hospital at the dialysis unit, which was started around 2018, and it has 2 nephrologists. It has been with 4 nurses, but currently we have now 2 nurses for some of the reasons. And we have between 6 to 8 sessions per day, and in a month we enroll up to 10 patients for those who are enrolling on chronic dialysis care. We set out to mainly look at patients with chronic kidney disease, and we excluding all patients who came in with acute kidney injury, but also patients who were under 18 years of age. And one thing I have to mention is that for most of our patients, they actually do 2 sessions per week. Rarely you would see maybe 1 or 2 patients who can do 3 sessions, and for some reasons, we try to make them, do 3 sessions, but those are very few patients. And so, for most of our patients, we are doing 2 sessions per week, and each session is lasting 4 hours. And because of the supplies that we get, all our patients were subject to the same dialyzer sizes of 1.8. And for purposes of our study, we were looking at patients who are in the care, that's chronic care hemodialysis. These patients should have been on dialysis for at least a minimum of 2 weeks. And these are patients who are receiving regular hemodialysis sessions. And so what we would do, when a patient comes in, we see whether they are eligible, we consent them. Once these patients have consented, then we go on and collect their baseline characteristics, demographics, clinical characteristics, but also went on to do the blood samples. And these blood samples were particularly taken at the beginning of the session, but also at the end of the session, once the machine we had reduced the flow, and after like 3 minutes, then we do arterial blood sampling. And we would take off 5 meals before and after, and we're able to do the blood tests. And specifically, we're doing complete blood count, we're doing creatinine, urea, and albumin for our patients. And we use these different equations that you can see, which have been proposed to assess hemodialysis adequacy. And we defined our hemodialysis adequacy as a single pool KT over V of equal or more than 1.2, and then a urea reduction ratio of equal or more 65%. We have so far seen 90 patients between the period of August up to now, and we have excluded 2 participants. These were basically below 18 years, and 88 of them were meeting the criteria, but 2 patients declined consent, and one of the patient samples clotted, and so couldn't go on to analyze. And so we have so far analyzed data for 85 patients. These are some of the baseline characteristics. Most of our patients were middle-aged, 50 years old, and they were majority of males. And most of our patients, like you can see, because of the resource limitations, they fund their own dialysis stations, and this has some implication. Most of our patients, like my colleague had said, were hypertensive patients, up to 78%. And the mean urea was up to 120 for all the patients, 118 for the patients that we dialyzed. And for most of our patients, the blood flow rates were 246. This was our mean flow rate. And for fascicular access, for most of our patients, they were actually having temporary central venous catheters. You can imagine that we only had 3 patients, which is up to 3.5% of our patients who have got the standard of care, which is AVF. For most of our patients, they had hypoalbuminemia, which was a severe hypoalbuminemia of up to 2.6, with the lowest up to 1.5. And the HB levels were, most of them were anemic patients with HB of 8.3. And the most common intradialytic complication was the hypertension, which was up to 29% of the patients. And for us to get our hemodialysis adequacy, only 23 patients, which accounted for 27% of our patients, had adequate dialysis by single pool KT over V, and we were 95% sure that our true value lies between 17 to 37. And this was followed by URR, which was 21, and this accounted for 24% of the patients. And when we looked at the factors associated with hemodialysis adequacy, we realized that when we got all our variables and ran a model, which was the logistic regression, we realized that hemoglobin was independently associated with the adequate hemodialysis. And this way, we did it both as a continuous variable. When we did it as a continuous variable, this is what we were able to get, that if you have your HB, for each single increment of unit HB, you had at least up to 2 odds of having adequate hemodialysis. And this was also followed by blood flow rates. Like my colleague has said, the blood flow rates of 250 mils per minute was also independently associated with hemodialysis adequacy. When you compare our results with what others have found out, our hemodialysis adequacy was 27% by single pool KT/V and 24%. And you see that these values which are indicating low adequacy of hemodialysis. And so one of the things we felt maybe could explain this is that the vestibular access for most of our patients are using temporary access. But also we know that for patients who have got adequate dialysis, the standard of care should be AVFs. And so this we think is partly. But also when you look at most of our patients, they came in with anemia, with HB of 8 and below. And we think, among other things, this could have been responsible for patients' inadequate hemodialysis. And also the other thing, not forgetting that for all our patients, most of them were receiving 2 sessions per week. When you look at a study which was done in Egypt from a similar setting, a hospital setting, a regional referral hospital, they had more or less similar number, 100 patients. It was a cross-sectional study. They found hemodialysis adequacy was up to 40% using single pool KT/V. And this was, we think this is a different, slightly different from ours, because most of your patients, up to 60% of their patients, were actually using AVFs, that is vestibular access, which favors hemodialysis adequacy. The other thing that was also unique in their population, that most of their patients were receiving 250 as a blood flow rate. And in Tanzania, the same thing happened, which my colleague had also talked to. And when you look at the factors associated with hemodialysis adequacy, for us, we found hemoglobin levels and blood flow rates of more than 250. And the same findings have been found out in Tanzania. They found that HB of more than 10 grams per deciliter was associated with hemodialysis adequacy. Of course, for them, they had other things like the gender, the surface area. For us, we used 1.8, and for them, they found that anything that was 1.4 and above was associated with hemodialysis adequacy. And of course, another study which was done from Iraq also found the same findings of blood flow rates. For them, they specifically looked at this at 300 mils per minute. Our strengths, we feel this is in our setting. This is the first study we are doing, so we feel it gives us some weight. But also the other thing, we're able to use both single pool KT/V and URR, and so you can see both results which are somehow comparing. And the limitations, initially we thought we'd use a standardized KT/V, which looks at a weekly adequacy, but we were unable to use this for one reason or the other. And in conclusion, our study has adequacy of dialysis at 27%, which is, we think, is a low hemodialysis adequacy. And we feel hemoglobin and blood flow rates could be used to improve the the hemodialysis adequacy. And so for this purpose, we think if we can have targeted interventions, specifically to increase hemoglobin, but also to optimize blood flow rates, we could go a long way to improve our patients' hemodialysis adequacy. And so we feel one of the things that can be done is to have a prospective study also to include a big number of patients, but also look at other centers. And we think all these can be put in place and improve the dialysis adequacy, and so improve the quality of life and overall survival benefits. We acknowledge the following. Thank you.
Tabiam Kama, thank you very much for that elaborate presentation. Let's just be reminded that we'll take questions at the end of the session. We have 3 presentations left, and I'm sure we'll go through them. Next, I want to invite Dr. Oriba. You're not even looking at me. I want to invite Dr. Dan Oriba, who is a physician and the head of Department of Internal Medicine at Lacho. When you hear Oriba, you automatically think about peritoneal dialysis. He's one of the few who have been very courageous to do PD. We all know that many times we want to do it, but we fear. One, we don't have the fluids. I have attempted to concoct, manufacture, and make my own PD solution. I actually saved a child once. I tell this story to anybody who cares to listen. This child blessed me with a chicken, but I ate that chicken and all the energy that I was using for PD ran out because I had to do it myself, do the exchanges. So we want to hear from Dr. Oriba what he is doing, and we can probably learn from him. Over to you.
Thank you very much, my senior, Dr. Rose, and to all my mentors in the house, Professor Kale Subra, Dr. Grace, who encouraged me to do the things that we are doing in northern Uganda. Very much for this opportunity to present again on peritoneal dialysis. I will take this opportunity also to give an experience of all the different trainings that we have been having under International Society of Peritoneal Dialysis, and also at the same time the Saving Life ISN programs. So basically my slides are very few on the introduction. Acute kidney injury is still very common and needs renal replacement therapy. And in most cases, you find that peritoneal dialysis is being used as an alternative to hemodialysis. But most of the studies that have been done across the globe have shown that there is no superiority of hemodialysis over peritoneal dialysis. And the choice of these two modalities actually depends on the expertise of the center and the people who are trying to offer these services to the patients. And at the same time, the outcomes are similar or among PD and hemodialysis. However, when it comes to correction of details, especially electrolytes abnormalities like hyperkalemia and the rest of it, you find that PD tend to correct those abnormalities much slower than hemodialysis. But by and large, it's important that we understand how peritoneal dialysis is done and incorporate it in our daily management of patients. Peritoneal dialysis also remains very effective and safe dialysis modalities in patients with AKI, according to systematic reviews and meta-analysis of RCTs which were done 6 RCTs, you find that peritoneal dialysis is associated with shorter time to renal recovery compared to hemodialysis. And there was no difference in survival, infections, or bleeding rates compared to other renal replacement therapy like CCRT and the rest of it. So this still gives us more weight to make sure that in the near future we find that peritoneal dialysis is improved and started very well in this country and probably also takes effect. What is the was why do we go for peritoneal dialysis? When we started this, I think I communicated, Dr. Chigundu Daniel was my mentor in undergraduate. He supervised me for my 3 years in medical school. So we shared this with him, and he told me that it would take a long time for Gulu and northern Uganda to get hemodialysis. But it would be better if you explore other methods of dialysis. And I think he remembered, he told me about peritoneal dialysis. He said, do the people of Gulu have safe water? I said, no, doctor, we don't have this in it. But we can try to look around and see what can be done. We really discussed that, and the plans to start hemodialysis in Gulu, and at the same time to make sure that renal care is put at that level. But up to now it has not been taken effect. You find that our patients travel 360 kilometers to come to Kampala, and most of these patients, when they come to us, they have classical coma scale of 8, 9. They are really so uremic, they are very sick, they are dying. They have refractory electrolyte abnormalities that need urgent care. And looking at other modalities of treatment. So you want to say you want to put these patients on some kind of modality to make sure that they get better. Particularly, no particular form of renal replacement for AKI has been clearly shown to have benefit, whether it being hemodialysis or peritoneal dialysis, or the most complex continuous renal replacement therapy, which is mostly used in ICU. And I think recently, from our visit to World Congress of Nephrology, if you attend the session on CRRT, you find that it's a very complex procedure, and it requires a lot of money, and it will take us a long time to get there. But I will share with you experiences too. I'm not promoting PD, but I think PD mimics continuous renal replacement therapy, because it is really quite gentle to the body if you prepare the fluids very well, and if it is really there. And even the most sickest of patients can actually pull out from it. And the choice of renal replacement therapy, of course, is dependent on a variety of factors, including the availability. We don't have to wait for Gulu to have hemodialysis in order to save patients, so we had to look at alternative ways of saving patients who come from Sudan, who come from Congo, who come from Soroti and other districts. So the expertise of the clinician. I'm not an expert in peritoneal dialysis. In fact, I mostly I have one of our interns here. I always tell them in the ICU that I'm a masquerader in this thing. But we thank God that with the little knowledge that we have, He can still give us to save life. And then, of course, the hemodynamic stability and so on. So it's very important that you, as the clinician who is managing this patient, take into the account what do you have and what are the options that are available. In most cases, the options not being available make us take the most difficult decisions. And I would give you, again, a story of this young man. He was 19-year-old, he is sickle cell disease patient, came with a bleeding from the nose and the mouth and the anal region. And, by then Ebola was a problem, so they immediately in medicine ward, they separated him in the Ebola unit, in the isolation unit. And I said, please, let us run a kidney function test in this patient with sickle cell disease. And, everyone feared to take of his sample. So during the time to take the samples for the kidney, for VHF testing, I went and took the samples, and I found his creatinine was 23 and urea was 780 milligrams. Then I said, no, this is not viral hemorrhagic fever. This is actually uremic bleeding diastasis. So we took the bold step of taking this patient to ICU, and he was our index patient. I remember I talked to the late Dr. Cyprian. I said, Dr. Cyprian, I've been working on this formula for peritoneal dialysis. What if we try this in this patient? Do you think it's going to work? So he said, if you think it's going to save him, then please go ahead. I remember Dr. Cyprian rolled the ultrasound scan machine to ICU himself, and we placed the PD catheters, 2 NG tube catheters in this patient. We did several sessions of dialysis. That day we did 5 sessions. It was already almost evening hours. Then the following day we did another 7 sessions in a day. And the boy woke up and he was discharged from the hospital. That was our index case. So when that became successful, then he said, okay, Dr. Dan, I think your thing probably works. You need to start improving the formula. And I will tell you, the formula was very complex because we had to add magnesium sulfate, we used to have sodium bicarbonate, we had to add calcium gluconate, we had to add so many things on the fluid. Calculating it was very, very difficult. But at the end of our presentation, I'm very sure everyone here can be able to make the peritoneal dialysis fluid. And let us just go slow on it. So again, in northern Uganda, we are very poor, with no access to cheaper dialysis option, whether AKI or CKD. Most of the time, my colleagues have told me that, Dr. Dan, why have you moved back to Kampala? I said, when I come back to Kampala, I will be jobless because I will be seeing Professor Kalesubula, Dr. Grace Kansime, Rose Muhindo, and the famous Dr. Bate. I will be jobless. But in northern Uganda, where the Dr. Bates are not there, and Dr. Rose Muhindo are not there, I can still consult them when they are in Kampala, and I transfer their knowledge to northern Uganda and help manage these patients. And I think these collaborations has been very good. Professor, I think I've really disturbed you. Even sometimes in the night, he knows I call him. This is not politics, you people. I don't like politics when I'm presenting. But this is the truth. I send them patients and I call them when I'm stuck. And it has been very helpful because, you know, I don't have a formal training in nephrology. Of course, I'm undertaking my fellowship by International Society of Peritoneal Dialysis. This case here, we have just managed this child last week, was a 13-year-old referral from Soroti with a Glasgow Coma scale of 9 out of 15. The diagnosis was severe malaria complicated by AKI KDIGO 3 with pulmonary edema and uremic complications, especially uremic neuropathies, bleeding diathesis, and gastritis. He also had uremic pericarditis. Really required dialysis. Creatinine was 17 milligrams per deciliter. Urea was 725. You know, they come with very huge urea, and I don't know because the time frame. So the patient was admitted in ICU. PD was started using 3.5% dextrose-based Ringer's lactate solution. You see how simple it is. Now it is only Ringer's lactate and dextrose 50% that we are using. It works. You don't need to complicate your life. You just need to make sure that, and over time we started killing off the other electrolytes which are not important. And please, Ringer's lactate, if I ask you, you know what Ringer's lactate, the percentage of calcium, the percentage of potassium which is there. I mean, the osmolarity of Ringer's lactate mimics that of the natural body. And so when someone comes with a lot of volume overload, you want to prepare a higher osmolarity that is going to extract that volume from that patient. So you need to understand how much fluid, what is the osmolarity of that patient at that point in time. So I always calculate the osmolarity of that patient by using the random sugars of the patient, by using the urea, and then the glucose. I mean, once you calculate the osmolarity of that patient, it gives you the choice of which fluid you are supposed to prepare to extract adequately from that patient. But if you do it blindly, you will still succeed, but it will be a much slower process. So the patient recovered from ICU day 6, creatinine 2 milligrams, and urea of 55, became conscious, and we discharged to pediatric ward. Yesterday I called back in the hospital and they told me they have been discharged from the hospital and the creatinine was 0.7 and urea of 24. So this has normalized. This AKI is very rewarding because the patients actually, they get better. I fear CKD because it's dependent on the patient paying their money. Once the money go dry, then you, the clinician, is left with a much more problem of talking to them, trying to counsel them that death is inevitable and the rest of it. So this is the follow-up care. And you can see, if you have never seen uremic frost, this girl here came with uremic frost, malaria-induced. She had full normalization of renal function. And you can see most of them come with anuria. And normally once you get to the polyuric phase, which you need to calculate their urine output basing on their weight, and you find that it is really greater than 2, you really need to start fluid replacement in this patient. And because once you don't start fluid replacement in this patient, again, they have a prolonged cause of AKI. Again, let us look briefly this paper which was published in New England Journal of Medicine 2021 on peritoneal access and principle. A catheter traversing the anterior abdominal wall is placed with its tip in the pelvis. Dialysate is instilled through the catheter and allowed to dwell in the abdomen, during which time solute diffusion and ultrafiltration occurs. The dialysate is then drained and the process is repeated. That is as simple as that in peritoneal dialysis. This you see here is the Tenkov catheter. And then this is the peritoneal membrane. This is your muscles. Once you instill fluid, ultrafiltration will occur through glucose-dependent diffusion. Glucose is supposed to cause you the osmotic shift that is there. Of course, with the newer peritoneal fluids which are commercially manufactured, they are looking at so many other, fluids, because glucose is associated with infections and other things in prolonged hemodialysis, peritoneal dialysis. But patients with acute kidney injury actually have excellent, recovery with the dextrose-based solution. Now, as blood in the peritoneal capillaries come into contact with the dialysate that you have put there, the solutes in the blood diffuse in the dialysate. The osmotic gradient created by glucose in the dialysate affects ultrafiltration of water from blood into the dialysate. And even for pulmonary edema, it actually works very well if you do it with the higher concentrations. And over time, glucose diffuses from the dialysate in the peritoneal cavity, and it leads into ultrafiltration, and you can really remove it out. Now, when you want to remove this, after removing this out, probably at the end of it all, you can instill intraperitoneal antibiotics. And we do with ceftriaxone to make sure that they don't get infections. And we lock the catheters with heparin so that the proteinous materials and the rest doesn't block the catheter. That is if the patient can afford really the heparin. But you find that sometimes they don't even have heparin. And we do this free of charge. We don't charge them except they buy the catheters that I'm going to show you. This is preparation of the dialysate again. We have students from Gulu University and our nurses, and that one there is one of our residents from Bicocca University, Milan, Italy, and she was rotating in internal medicine. PD solutions, of course, consists of water, osmotic gradients, electrolytes, and minerals, and of course, the most common preparation that we prepare in our ICU is 1.5, 2.5, 4.25% base solution, because 5% is not very good with the peritoneal membrane. Okay. And we have summarized the osmolarity there already, 346. The osmolarity of the body is quite lower than that, so all these fluids are able to do for you both dialysis and ultrafiltration. So, the benefit of the ISN Young Saving Life program, from NG tube placement with multiple complications to sterile standard hemodialysis catheter percutaneously placed as an alternative to standard peritoneal dialysis catheter, which is not available in the country. So at the moment, we are using percutaneous placement with the hemodialysis catheter. We use 12 French, sometimes 12 French 15 centimeters or 12 French 19, 17 centimeters, depending on the patients that are there. And this, and this has really worked very well. And great thanks to my mentor, Professor Rasha Dawish from Egypt, Dr. Brett Collis, South Africa, Elaine Bowes from the US, and Dr. Nicola Wayne from South Africa, and also Professor Kale Subura for making all this possible. The results that we have done so far, majority of the patients that come to our facility acquire acute kidney injury from the community, 95%. Those are 60. Only 1 or 2 children acquired it from the hospital. 20 of them presented with tea-colored urine and uremic frost was 7%. 32 patients initially had mechanical leak dialysate. Why? Because we were still using NG tube. Now with this, we have eliminated leaks. And of course, 2 had early peritonitis. Risk factor for acute kidney injury. Most of our patients had anemia less than 9. Malaria was the most common cause of AKI. And some of them, which you'll see there, are known. We dialyzed 2 patients with the toxins. I mean, they were bitten by snakes, so, and they had snake envenomation, and one was a bee sting, and those are actually very bad. The snake patient, one of them survived, one passed on. The bee sting patient survived, and they get very bad rhabdomyolysis associated AKI. Majority of the patient had low HB, and the mean was 7.19. Now, indications for starting dialysis in our ICU was evidence-based, but most of them had electrolyte abnormalities, especially hyperkalemia, which were not managed with the medical treatment very well. Refractory hyperkalemia. Dr. Grace Kansime made a presentation, I think, in 2023 on hyperkalemia, how refractory, the hyperkalemia is, and in terms of the management. So it is really so debatable, but these patients were very sick, and they had ECG findings of hyperkalemia, which we do it for every patient during and after dialysis. So the duration of hospitalization, this is the Kaplan-Meier's curve showing the mean duration of hospitalization for these patients were 11 to 17 days. That is from the time of admission to the time of discharge. I've not analyzed the duration of ICU stay, which I think we are going to do again. And you can see that. So they take longer. And so this emphasizes that probably early referral, early management of patients with AKI is much, much more better, so that we prevent them from getting dialysis complications. Lastly, there was a significant decrease in median serum creatinine after dialysis. Interquartile range, that was 9.6. Interquartile range was 7.2 to 15 at baseline, versus 1.7. Interquartile range 1.3 to 1.9 at discharge. And this was significant with a p-value of less than 0.001. And conclusion, we still conclude that locally improvised peritoneal dialysis is safe and feasible for managing AKI in resource-limited settings, offering a valuable alternative where conventional dialysis is unavailable. Thank you very much for listening.
Thank you very much, Dr. Dan Oriba. Another round of applause for Dr. Dan Oriba for the fantastic work he's doing in northern Uganda, saving all those lives. Thank you so much. At this juncture, allow me to invite Dr. Caroline Aujo for the next talk, which will be on on peritoneal dialysis in the outpatient setting. Dr. Aujo is a pediatric nephrologist at Mulago National Referral Hospital. You're welcome, Dr. Aujo.
Good morning, everyone. So I'm Dr. Carol from Mulago. My bio has disappeared. So I'll say a bit about myself. I got M.Med. Ped from Makerere University. I did Master in Pediatric Nephrology from UCT. I'm also a fellow of the ISN from Red Cross Children's Hospital, South Africa. So I work in Mulago Hospital with the team that works there. So we wanted to share our experience with peritoneal dialysis at Mulago Hospital. So I came back in 2019, just before COVID, with a lot of energy and started doing some PD with improvised supplies. And then 2023, we stopped a bit, but currently we resumed again doing with Dr. Bate. So that will be the outline of my presentation. It's good Dr. Oriba has given a lot of background physiology and how PD works, so we've not gone into all that. So acute kidney injury is common, as we've all seen in our environment, and mostly in low middle income countries it follows infections, as opposed to the developed world where it can follow surgery, elderly patients. For us it's young patients following infections, And even us here, we have a lot of severe malaria, sepsis, pneumonia, diarrhea, dehydration, and I think at the moment, severe malaria is the commonest cause of AKI. Common indications, uremia, encephalopathy, prolonged anuria, fluid overload, and electrolyte disturbances. So, again, a lot has already been said, but it's a well-recognized modality, and many centers use it as a PD-first policy, and even in centers that have both PD and the conventional CRR renal replacement, the extracorporeal, they will still choose PD first for acute and chronic dialysis. So you can use, it can be automated using cycler machines. I think the famous one is the Fresenius and Baxter, but you can also do it manually for both acute and chronic. Manual exchanges, which we call CAPD, or you can also do it for acute kidney injury. But if you don't have all those with the conventional PD fluids, you can still do PD with improvised supplies. You make up your fluid, and there are now well-recognized published guidelines for that, and we also improvise with catheters, feeding tubes, central lines, chest drains. My professor used to say anything that has holes that you can safely put in the peritoneal cavity that can let in fluid and drain it out. So several studies, so the IS, International Society of Nephrology, International Pediatric Nephrology Association, and the International Society of Peritoneal Dialysis, they came up together and formed the Saving Young Lives program, and they have really trained a lot of clinicians across Africa and even beyond to do PD, and there are several success stories with PD. So this is the first report from our hospital on acute PD cases done in 2020 to 2022. Wanted to highlight our experience and describe outcomes, really, renal survival, patient survival, and the complications that we observe, and all the cases were. We managed as a team by primarily spearheaded by me. Dr. Rose Muhindo said she managed one and she got tired because she was doing. My approach has been, I manage while training. And if I go to a unit, you call me for a patient, even if it's now like Mulago Women's Hospital, I do not start until I see there's a team of nurses so that we do the PD while I train. I train you so that when I go home, work continues. Then I come tomorrow, it has continued through the night, you know. I will take phone calls. When the weekend comes, I go home, but work continues. And at the end, we have had a number of nurses who are now comfortable with doing the exchanges, and even some SHOs will say, so if they put the catheter and I'm busy doing something, the SHO can initiate and then we continue. So we reviewed the charts. There are not many patients. We had about, so we reviewed the charts of those patients. We collected data on their social demographics. We took the diagnosis recorded in the file as the cause of AKI. All patients were dialyzed using a feeding tube, nasogastric feeding tubes, with improvised, put by the surgeon in theater. We inserted PD within a few hours of the catheter being inserted, using 50% dextrose with Ringer's lactate, and there are formulas for making that fluid. And we start with fill volumes of 20 ml per kilo. So we do the PD manually in the high dependence area, and only 2 of our cases were done were done in PICU. And as I've said, we do the PD while also training. So we use burettes. I think we all know the burettes for accurate measurement of the fluid in and fluid out, and routine monitoring of the patients continues. So we also have the monitoring charts. So we just wanted to describe our short-term outcomes in terms of renal survival, patient survival, and the complications. So we had 11 children during that period. It was just around COVID, but we only found 9 charts, 9 files. Most children had oliguria and edema at presentation. The mean age was 27.9 months, and 55% were male. So in terms of commonest indications were fluid overload and severe hyperkalemia. The distribution of the diagnosis, so there was severe malaria, sepsis, and diarrhea with dehydration. We had one child who had burns, was in ICU, but also became septic. So as already said, the initial field volumes were 20 mL per kilo of PD fluid, and the 3 patients, we had to escalate the field volume to 25 or 30 mL per kilo in order to increase the adequacy of the dialysis. The PD fluid, Dr. Riba has explained the concentrations, but we mostly, so 1.5, 2.5, or 4.25%. Most of them were using 1.5%, but 3 patients who had fluid overload required initiation with 2.5% solution. The cycle length were 90 to 150 minutes, with the dwell times of 60 to 120 minutes. So I'll say here that because it's manual and the team gets tired, so we start with about 60 minutes dwell time, and then we build on maybe 2 hours so that they are not doing a lot of exchanges. And I must say that the 3-way tap has really performance of improvised PD, because you can achieve a closed system with a 3-way tap. So we use the burette with the Ringer's lactate bottle with a feeding tube. Then the 3-way tap connects to the feeding tube to the patient, and then to the urine bag as our drainage bag. So as shown in that picture. So the 3-way tap is all the team that the team that will keep turning it between the patient, the drainage bag, and your dialysate fluid. So the mean duration of hospital stay was 23 days. As we've seen earlier, they really, AKI increases length of hospital stay. The mean duration of dialysis was 7.5 days, range 1 to 12. We observed hypokalemia in 4 of the children. So hypokalemia, you may take it as a complication, but it's something that is expected. So many studies won't actually take it as a complication when you initiate PD. So 3 of the 9 patients had more than 1 complications, and only 2 developed peritonitis. There's always a fear of peritonitis, but 2 out of 9 only got peritonitis. 5 children had no PD complication if we remove the hypokalemia. Renal function recovered in 6 children completely. 2 improved. For PD to be discontinued, did not improve. But that one child had PD for only 1 day because we started late. 5 of the children were discharged. 4 died during admission, but of those 4, 3 had recovered their renal function, and they died for other non-renal causes. So just a recap of what I've already said, the mean age was 27 months. That's about 2.5 years. Length of hospital stay, 23 days. Duration of PD was 7.5 days on average, with the interquartile range of 5 to 10 days. The peak creatinine at initiation of PD was, median was 610, with interquartile range of 400 to 708. And that is the urea was 38, with that interquartile range of 35 to 46. And potassium, as you can see, was quite high, 8.1 with standard deviation 6. So that is one of our patients, and there I'm working with an SHO, but around us there's another team that we are actually talking to. So the indications for dialysis, most of the patients had more than 1 indication, I think, as you've already seen. So this is just how many times we are having the indication out of the 9 patients. Fluid overload was 6 times, metabolic acidosis 3, hyperkalemia 4, uremic encephalopathy 2. Complications, okay, thank you. So we have mechanical and infectious related complications. So catheter complications, blockage and leakage occurred 2 times each. Catheter tip displacement. So when the surgeon inserts the catheter, you want it to be in the pelvis. So in one case, it moved away and went up to the right hypochondrium. And then you can't actually drain. You will feel the abdomen, but the fluid won't come out because it's in the pelvis and the catheter has gone out. So part of the PD is every day you look out for complications and address as they come. So as I already said, 5 had no complications. We had peritonitis in 2. People fear peritonitis, but PD can be, peritonitis is not the end of the world. It can be prevented, but if it happens, it can be managed. So we inserted antibiotics into the PD fluid so that it goes into the peritoneum and you increase your dwell time. So I put this other chart to also show that if I include hypokalemia, it happens a lot, so you have to anticipate it. So 44.4% got hypokalemia, catheter leakage and blockage as shown there, and no complication was 1 patient. Peritonitis was 2. But on the other chart, I'm showing that if we remove hypokalemia, there were no complications. So here, just summarizing the characteristics of all the patients in terms of their age in months in the first column, and then the length of ward stay. So the catheter size, do I have a pointer? The catheter size, we are using a feeding tube, so then we are using size 12 or 14. And I want to say that the patient who used the size 10 catheter is actually the one who used 2 catheters. Most patients use 1 catheter during those average duration of 7 days. So the catheter blocked, then it displaced, and then we had to get the surgeon to insert a new catheter. So most in this column, I'm showing that they all improved and were discharged. And for those who died, so one had needed a catheter revision. We couldn't get the surgeon up here. Okay. So these are the indications, the 2 indications for those who required, who had more than 1 indication. The catheter size, this is the feeding tube. So from experience, catheter size 12 or 14 works better than the small one, because this one we actually had to change. This patient died, but creatinine was improving, but then we required a change of catheter, but we failed to get the surgeon. But also this patient had obstructive uropathy and is 1 month old, the youngest. This one had RDS, and that is the time of COVID, was actually suspected to have COVID, even though the kidney function had recovered. This one died from bleeding, I think had DIC. This one died from non-recovered renal function, but had PD for only 1 day, so it was a late start. Yeah. So the renal outcomes, I would say that not improved was 11.1%, recovered was 66%, and we discharged 5 out of the 9 patients. So I'm just comparing with other studies. Sorry, I'm just summarizing. Most of the studies done in Africa, improvised supplies, PD successful, PD works, PD saves lives, and we should do PD. They are also using improvised catheters, feeding tube, chest drains. Some centers have both improvised fluid and conventional fluids. And peritonitis, yes, it happened, but it can be managed. But our rate of peritonitis was low. And when I train them, they really have to make sure they prevent peritonitis. Also, we note that compared to other studies, indications for peritoneal dialysis can be more than 1. The length of stay is comparable to other studies. I just want to say that most of our patients are young. We are doing a lot of hemodialysis also. That's why we have few. But it's because the younger population, Ringer's lactate is 500 ml bottle. If you put a big child, you have a lot of fill volume that you need. So it requires a lot of exchanges, and then you might end up with peritonitis. So we are taking mostly the young ones so that that 500 ml bottle may give you like 2 or 3 cycles. So it says our limitations, it's retrospective, we missed some files, we have few patients, but still it gives us an overview of our initial experience with PD and outcomes, and PD works and it can be done. So we note that AKI is common, PD is feasible, it's cheap and cost effective, especially where you don't have PD catheters for hemodialysis and dialyzers for small children and infants, but we need more sensitization on early recognition, prevention and referral of AKI patients. I want to also share this article. I love PD. I love nephrology, but I also love PD. This was my thesis for my fellowship. I looked at all the patients of a 10-year period who had been on chronic peritoneal dialysis in South Africa, and why are they discontinuing PD. It's published in PDI for those who would like to read more. Thank you very much.
Thank you very much, Dr. Ujo. Again, we clap for her. I admire the work that you do, you guys. And between you and Dr. Bate, I wish one of you would come and join us in southwestern Uganda. The same God who brought Dr. Kansime to join me in Southwest, I'm sure he can do it. And I am praying. Honestly speaking, I get very nervous when I get those pediatric consults. When you are presenting your slide on the baseline characteristics, there's a picture of a baby there, but I didn't know whether that was a pillow or a human being. They are too small and they really scare me. Now you imagine. They call you for months, weeks old human beings, and you don't know what to do with them. Nonetheless, we appreciate you. The next and last presenter for this session is none other than Dr. Chigundu. Dr. Chigundu, I am told that we are waiting for your presentation. It's a very special one, and he's going to talk to us about the different phases of nephritic syndrome. I know that many students run away from renal for 2 reasons: renal physiology and GN. GN is a very interesting subject. I'm very passionate about GN, and we're hoping that we'll be able to learn even more from Dr. Chigundu, who is a consultant nephrologist, and I'm sure you heard and know that he works with Chirudu Hospital. He's very passionate about establishing sites for kidney care, and for us in UKF, he has made us proud, and he has led to the setup of different satellite units across the country. The next one is going to be Hoima. Anyone from Hoima? There you go. Louis. Yeah, so we are very proud of Dr. Chigundu. He's an alumni of MUST. And that's always the foundation. So these are things of Amakere, what. For us, we first baked him, then we gave him to you. He did his fellowship training at the University of British Columbia in Vancouver. Over to you, Dr. Chigundu.
Thank you for the kind introduction, Dr. Rose. I'm going to use 10 minutes, and I hope in that time I leave a little idea of what goes on behind the scenes. I prepared this presentation of a very short time because I couldn't pass up the opportunity to spend 10 minutes talking about it, even though it's not my most prepared day. Yeah, but really what nephritic syndrome means is that there's inflammation in the glomerulus and there's resulting kidney dysfunction. And so nephritic syndrome is the clinical of glomerulonephritis. And phase means there's hematuria. Number one, there's hematuria. If there's no hematuria, there's no nephritic syndrome. Number two, there may be variable protein. Not sure what's wrong with the mic. Red blood cell casts, which means that you see the silhouettes of red blood cells embedded in a cylindrical matrix from term phosphoproteins, and these in the thank you. Or maybe okay. Yeah. And also they tend to have edema and hypertension, which are a result of volume retention, and kidney dysfunction or insufficiency, which is what you get from the renal function tests. So before you say nephritic syndrome, you need a urinalysis and you need an RFT. And what are the triggers? Glomerular inflammation. It could happen one of many ways, but the three main ways we think about it is there are antibodies that are bound either to a structural component of the glomerulus or to an antigen that is somehow implanted in the glomerulus but it's not native to it, and that's one way. Or there's been an antibody-antigen complex formed elsewhere, and then it's deposited in the glomerulus, and this complex then triggers inflammation. But the third route is sometimes you have antigens and you have direct complement activation, and then you have this inflammatory process. And the consequences, after the inflammation is initiated, you can have inflammatory cells, or you can also have proliferation of native cells, and this inflammation may result in some obliterated capillaries, and also it could result in rupture of the glomerular filtration barrier, which is why where there should be no red blood cells in the urine, now they're there. So this is the usual way they show: low urine volume, edema, hypertension, sometimes uremic syndrome, and also because there are many varied causes of it, these will be represented in the clinical presentation. If it is good pasture syndrome, there could be hematemesis along with the hematuria. If it is HSP with IgA nephropathy, then the person might have a rash. So in practice, even though when we list it, when we make a simple list like this, it looks very obvious, in practice there is variable severity, because sometimes someone is walking around or sitting here, and then it happens that they have very slight puffiness and they have microscopic hematuria. On the other hand, there's someone somewhere in emergency coughing up blood, very swollen, a big balloon, and passing bloody urine. So, essential labs we've gone over, and what I'll point out here is the red blood cells from glomerular hematuria are called dysmorphic. They're also called Mickey Mouse cells. And I'll show you this picture from an old paper that really pointed. You can see this scanning electron micrograph privilege pointer. Ears on the red blood cell. So it's not as neat as this on a urinalysis, but if you went up there, you can see this thing peeping. So if it happened that you're one of those who are passionate about using the microscope, this is something you could use to push the argument that this is glomerular hematuria. I haven't put a picture of a cast, but the other thing you look for is a cast. And usually when there's nephritic syndrome, we want to find acute problems, because when we fight hard, we might win. So we want to see if the kidneys are of a reasonable preserved size above 9. Because if they're below 9, it means we have a harder fight on our hands. But ultimately, really want for people who have nephritic syndrome, unless there's something convincing us that, well, this is an easy win, it's going to recover, we want a kidney biopsy. And this kidney biopsy is going to tell us, out of that universe of potential causes, what's the most likely. And this kidney biopsy, while you might have seen a biopsy report where it's just H&E on light microscopy, the influence of immunofluorescent microscopy on the evaluation of the nephritic syndrome is very heavy, and it's very hard to make true meaning of what's going on without it. You need to see inflammatory pattern, because as we said earlier, driving the problem is inflammation, which is starting somewhere in this glomerulus. And so I wanted to use this just to show you normal glomerulus, but I'll cut right to this one. And this is a normal glomerulus. And you can see that there are many white spaces in there that don't have inflammatory cells in them. And in between the spaces, you can see delicate tissue, not too thick, not too present. And you can see some cells, cell bodies in the background there. So this is a normal situation. To put it in a cartoon form, this is really it. You've got the glomerulus. I mean, you have the arterial afferent splitting out into these tiny capillaries, and they are surrounded by epithelial cells, and in between them there's the basement membrane there. I drew this cartoon this morning, so don't be too harsh on my art. This is a podocyte, and that's the basement membrane. And these are endothelial cells. And many spaces shown are empty. There's nothing going on in them. So this is what's happening in most of us this morning. Now, the most extreme disturbance is when you've got rapid loss of kidney function in something called RPGN. And I'll use this just to illustrate what could go wrong. So, in rapidly progressive GN, usually we're thinking about 3 or 4 problems. We could think about ANCA vasculitis, or we could think about anti-glomerular basement membrane disease, or aggressive forms of lupus, or, well. But just to start with anti-glomerular basement disease, I'm starting here because I have shown you the basement membrane. And so it will be easy to show. For the people on the other screen, that one. But this is the basement membrane, and now you can see that we have green antibodies that have tagged onto it, and these are the things that promote the inflammation. And when we look at the micrograph IF stain, you can see that, well, this is called linear deposition, and that's because we say it's linear because it seems to be outlining the capillary loops the same way as you have the glomerular basement membrane outlining the capillary loops. So this is what's going on the IF. But we also have a light microscopy corresponding, and you can see here, this is a crescent, but really aggressive. It's almost fibrinoid necrosis going on there. And then this is the glomerular tuft that should be beautiful and neat, but you can see, only when we do the IF do we see what's going on. And although I haven't shown multiple stains, this is usually IgG doing linear staining, but we stain, or they stain, I want to say we stain in a few years, courtesy of Rose, but we stain for multiple, the 5 classes of antibodies, and we stain for complement. So we can say with confidence that this is the antibody, it's an IgG, and maybe it's provoking complement or not, yeah? So to go to, and so these are just other pictures of anti-GBM. So to go to the post-immune, so a similarly aggressive glomerular, so light microscopy is showing us crescentic GN, but when we stain, we don't see those antibodies that we saw. And so we are starting to consider alternatives. One of the alternatives is ANCA-associated vasculitis, and in this case, the problem is not antibodies in the glomerulus. The problem is this inflammation is happening in the glomerulus because neutrophils are disturbed by antibodies. So when you send that ANCA test, when they do it the old way, they get neutrophils and they look for this fluorescent staining in the neutrophils, and then they can tell us if it is perinuclear. You can see these ones, the antibodies are, the staining is close to the nucleus, or cytoplasmic. And then you can name it as C anchor or P anchor. Or now, if you could measure these antibodies without having to use cells, you can now say anti-MPO or anti-PR3. So, but really, there's an inflammation problem starting somewhere. Yeah, this is an angry glomerulus with a big crescent. I took these slides from the AJKD Atlas of Kidney Pathology. Now, so we moved from the situation where we have one antibody. But I just want this to illustrate. The bottom line is still that there is inflammation, but in this, what I want to point out is that we know that antibodies can be one class or many classes. So there are situations where we will find that when we do these stains, we find a single antibody. So we find one IgG staining. And when we do the light chains, we also find one light chain staining. So it's something like this. None of even the IgG subtypes, none of the other subtypes, G1 or G2 or G4 is staining. We have just G3. That means there's one very specific source of this immunoglobulin. Yeah? And when we look at the corresponding light chain, you can see, I don't know which one is lighting up more here. Maybe both are lighting up. Yeah, but so sometimes you find just one light chain staining and one IgG staining. And that makes us look for a monoclonal source driving this antibody. And this is why when that patient comes, we are insisting on a kidney biopsy, and we want to send it out because we want these things to guide us to make good choices. Yeah, so. Well, lupus, sometimes if you have rapidly progressing GN, you might have class 3 or class 4 lupus. I haven't spent much time on the light microscopy findings because I'm selling IF here and I'm selling good biopsies here. But sometimes for lupus, you might find staining of multiple classes of antibodies. I have 5 minutes, I will finish. Multiple classes of antibodies. And and when we talk about lupus, usually we're talking about anti-nuclear antibodies. So you can see, I've drawn a cartoon for you. The antibodies are right there, and they're disturbing many nuclei in your body and provoking this inflammation in the many tissues that you know lupus can disturb. So we don't have a lot of IgA nephropathy in Africa, although some people are saying we should change the narrative. Our brothers in Kenya are telling a story where they think that it is more represented than we are reporting. We shall find out more from them soon. But I want to show this picture to show that while in the anti-GBM we had staining mainly of the basement membrane, if you look at this one, it doesn't seem to be organizing in little circles, highlighting the capillary wall, because this actually tends to stain the in-between, what's known as the mesangium, which I tried to show in a cartoon here. All this is my art copyrighted work. And this is the normal situation. You have nice capillary loops there, and you have mesangium, which is a little tissue holding them together, and it may have some cell bodies in it, but not too much. It's not overbearing and over-present. It's really a background feature just holding the capillaries together like flowers, just like a stalk holding a bunch of flowers. So this can happen in some situations where there should be few inflammatory cells or none. Now you can see that there are many inflammatory cells. And when people are in the lab looking at the biopsy, they are also describing, okay, they are inflammatory cells, but where are they? And here we can see that they are in the mesangium, but then they are also inside the capillary lumens. And different permutations of these patterns allow us to decide what kind of inflammatory process is going on and how to respond. And in the most famous case of post-streptococcal GN, it's almost, this is the kind of thing that's going on. You can see here, maybe you are not used to seeing them, but here I'll tell you, one, the mesangium is more obvious than it should be, and it's full of inflammatory cells, and you can hardly make out the clear white spaces in between. So there's inflammation in the mesangium and in the capillary lumens. I'll stop here because I wanted to make a brief sales pitch, and I hope I've made it successfully.
Thank you very much, Dr. Daniel Chigundu. So at this moment, we'll have a short Q&A. So I would like to invite all the speakers for this session to take up seats at the high table, and we will have a short Q&A since we are behind on time, just before our tea break. So the speakers can take up the seats, and I can already start to take some questions as the speakers take up the seats. Oh, don't mind. Any other hands before Dr. Javira? Okay, Dr. Bagasha is there. You can go ahead, Dr. Javira.
Thank you so much, Dr. Chaze, and thank you so much, the presenters, for your excellent presentations. Mine is a simple one, for just a comment. It might be beyond the scope of the studies that my brother Emma and David did, but I just wanted to know from your study about dialysis adequacy. I know there are many factors that like you showed, that will influence dialysis adequacy. Did you dig into how often these centers do a water analysis? Thank you. Because it influences a lot on adequacy as well in our setting. Thank you.
Thank you. The speakers can just note the questions down. Dr. Bagasha, we can take your question.
Thank you so much. So I have two questions. One is for the dialysis section. Recently, we had a patient who we have been managing, and she had long onset depression, and she was sick on and off for a long time. We didn't really know what was wrong. So we happened to do heavy metals and found that she had a lot of aluminium. So when we started to remove it, she started to be less drowsy. So I'm thinking that there's maybe a lot of heavy metal poisoning. So just a comment on if you've been able to identify this trend as well. Then my second question is for the Dr. Chigundu. They always ask me that all patients who have protein in urine, should we give them steroids, all of them? So maybe just to comment on that. Thank you.
The first question was to who? Dr. Bagasha? Dr. Riba. Okay. Any other questions from the house? Okay, we have Dr. Rose.
I'll take a question. Dr. Bate, thank you for your presentation. I know that when it comes to, those definitions for nephrotic syndrome, the very first one, I keep looking at it, and the way it is written, that you want the patients to be in remission, like on consecutive days, and you're using a PCR. I know you said that it's supposed to be dependent on the setting, okay? But I always ask myself, why did they put it there in consecutive days? How about just writing it as persistent? Like, I may not do one Monday, Tuesday, and Wednesday a UPCR. First of all, it's expensive. But then what is it really about the consecutiveness of the days, and what are the changes that you require really for protein? I know you're talking about subnephrotic. So are we expecting that the patient's UPCR can change just overnight? It sounds like a very weird question, but I think it's very practical in our setting. The second question was Dr. Chigundu. Many times when we see these patients with GN, of course, we have quite a number of things on our list of differentials. Diagnostics still remain difficult, whether it is to get a biopsy or whether getting just the regular, the blood tests, the specific ones like an ANCA or an ANA. In our particular setting, I know that treatment becomes difficult, just like Dr. Bagasha's question, should we give everybody steroids? And it's going to be the same question that these patients, when you're looking at them, do you want to just give them steroids and blindly assume that they are going to recover, or do you want to jump right ahead into adding other therapies, maybe combined with the steroids, just because you may not really be able to make the clear-cut diagnosis of what GN that you're dealing with, because you're being limited by the diagnostics?
Thank you very much. My question is to Dr. Bate. I know we talk so much about diuretics, and it goes deep into people's heads when we are fighting with cardiologists about the kilos of Lasix to give. I know you briefly mentioned it when you talked about hyponatremia, but can you please comment about diuretics in nephrotic syndrome? Because people are used to giving lots of diuretics, so when a nephrotic comes and they're this swollen, they will tend to give because this is nephrology. So please, can you comment? And again, still to you, Dr. Bate and Dr. Chigundu, the SGLT inhibitors, I know yesterday you told us a bit about them, and children, looking at them, we know, yes, the physiology, the pathophysiology is different, but any efforts to look at SGLT inhibitors and if they have any role in the nephrotic syndromes?
Maybe we take some more and answer at once. Yes, Dr. Nyende.
Thank you very much, the presenters. My question is the ones that presented about adequacy. I'm just wondering how many dialysis patients were having, because in 3, they're already having inadequate dialysis. Yeah.
Okay, so that one was to Adolf and I think Emma. So I see no more hands, so I think we can start to answer. Oh, Dr. Haujo has a question.
Thank you. I have a question for Dr. Chigundu. Nephritis. What is the nomenclature these days? So when we are training, they use nephritic, nephrotic, when you have blood and a lot of protein. And it seems easier to use that word when you have mixed picture and you're teaching students. But then you want them to understand what is nephritis, what is nephrosis. So when you have overlapping picture, what do you say? Now they say glomerulonephritis with nephrotic range proteinuria. So just throw some light on what should we describe and what should be the differentials.
Thank you for the question. I'll start with the last one. So, you are right, most of the world, when they are able to pinpoint the exact causes, they will not even be referring to the nephrotic or nephritic syndrome. They'll be talking about the specific cause. But when we look at our, the ICD nomenclature, International Classification of Disease nomenclature, we still have these two terms persisting, nephrotic syndrome and nephritic syndrome. And nephrotic syndrome is a full syndrome, as Dr. Bate pointed out. Sometimes you've got a component of the nephrotic syndrome, but you don't have the full syndrome. For example, you could have a diabetic with 3+ proteinuria, and well, when you do the ACR or PCR, it meets the criteria, but they don't have edema, they don't have any of the other things. That person would not qualify to be labeled nephrotic syndrome, but they can be labeled nephrotic range proteinuria. On the other hand, there are situations where people meet all the criteria for the nephritic syndrome, and then they also meet all the criteria for the nephrotic syndrome, in which case you can label them as nephritic and nephrotic syndrome. Or conversely, there's another situation where someone has nephrotic syndrome, and when you look at the urinalysis, you see red blood cells, in which case it's named an active sediment, and you will say there's nephritis, but they will need to fulfill all the criteria. I don't know if that's fair. Somehow, middle. We shall get answers from, we have an offer from.
Thank you very much. I think we still retain those definitions for teaching. My question is actually to Dan. I appreciate the high level, but I would have expected you to talk more about the urine. I think in making diagnosis of these problems, as nephrologists, we always have to run to the urine as a first tool because it's much easier to look at. I would like you to give a comment. I appreciate the pitch was for us to go higher, and I think Rose will take us there. But then I missed the component of where you are talking about the diagnosis of GN and the usefulness of the urine. A comment on that. My second comment is actually to the pediatricians and also Dr. Riba. We thank you very much for bringing PD. PD really needs champions, but I also want to challenge Dr. Riba a bit more that you probably have to take what you are doing to another level and perhaps partner with some of the manufacturers we have in Uganda, and we begin making our PD fluids here. I think the tendency is for us to always look to the West to go out, but if the Trump administration has taught us anything, we need to begin using our brains. And you've talked the journey very well. You have innovatively been able to manage 60 individuals. The next level should, even as you go to study, because when you go to study, you'll again adopt the Western styles. I think you should critically think about working with the individuals you have, the team we have here, the Bates, and you actually help these individuals to develop our own peritoneal fluid. This is what we should do. I submit. Thank you very much.
Thank you very much, Professor. Dr. Dan?
Thank you. We cannot overstate the urine. Thank you for the comment and the emphasis, Professor Kalyasobola. There must be red blood cells in the urine. And when there are red blood cells, then you are wondering where they came from along this urinary tree. Did they come from the bladder? Is there a stone cutting the ureters? Or are they truly from the glomerulus? And the things that bias us to believe that these RBCs are from the glomerulus would be if they are dysmorphic, if they are coexisting with casts, because casts come from the tubules, and it means you see these red blood cells embedded in a matrix, cylindrical matrix. And if you see red cell casts, then you believe that these RBCs are from the urine, from the kidney. And some people have tried looking at associations between, if you see purely hematuria with no proteinuria at all, then maybe there's a mechanical cause lower down the tree. And if it's someone at very high risk, people above 50, you might send them for a cystoscopy, as I did on Monday. But these things make you think that this nephritis is from, these RBCs are from the urine. Regarding the treatments, should we give all of these people steroids? Well, yes, if we believe that there's kidney function to be saved, we have normal sized kidneys and we see active inflammation, we give them to the nephritic patients. Yes, we want to give them steroids, but the trouble is we cannot use the steroids forever because the steroids come with burdens. And the other thing is that the steroids are not as targeted as we would like for all the immune responses. So the additional work is to be able to refine the treatment. When we go to the people with excessive protein in the urine, do we give them, all of them, steroids? The answer is no. The answer is maybe if you believe there's a nephrotic syndrome, which Bate is more qualified this morning to talk about than I am, then if there's a nephrotic syndrome, yes. But if there is proteinuria that you think is probably because of reduced GFR and increased hydrostatic pressure at the individual nephron units, then the answer is to reduce the pressure at that level. And the answer is not an inflammatory problem. But I will hand over now.
Thank you, Dr. Chigundu. I would just agree with you, only that I think what you've said. So I think one of the things that is in children is that we are preparing them for you later in adulthood. And the moment we think it's not minimal change disease, we need to investigate and confirm the diagnosis and then treat that diagnosis so that we have longer life for the patient we send to you as they grow up. We know what we've treated. So I tend to say we shouldn't use just prednisolone. The problem is, if, for example, we have a child with SLE, this time we've detected proteinuria, we give prednisolone, 2 months or 2 years later, they now have new problems. We lost the chance to quickly investigate. So whenever we have any sign of glomerulonephritis, and the setting allows, I think that matters. And the setting allows, we prefer to investigate as quickly as possible, find the cause. Sometimes the sickle cell disease affecting the kidneys, sometimes it's IgA or any other diseases that when we treat probably would have used a different drug. And so I think when we see a flag, we tend to investigate quickly so that we, in case there's anything else. A few times we even had HIV nephropathy, and so we want to quickly investigate, then find the exact cause. But yeah, you're right. And I think the approach would be different also for adults than for the child. Then Dr. Muhindo asked about daily consecutive days. What I know is that even in Canada, where there was every resource, we were not doing urine protein to creatinine ratios, especially daily, and as they display them for diagnosis. We were only doing them in cases where we are looking at those diseases like Alport or diseases that have little protein, and we want to confirm is there proteinuria or diabetes, and we want to pick up protein, but not for nephrotic syndrome. But the part of consecutive daily, I think even in our resource setting, of course, again, even in our setting, resources can matter. We should do it because sometimes when, especially patients, sorry for dividing the two groups, patients in government settings are harder because you see them once a week, and even affording a urinalysis is expensive for them. Sometimes even the urinalysis is not available. And so those daily is hard. But even in those in government and those in private, what I tell them, buy a dipstick bottle. It is 30,000 with 100 strips. The transport you put in to come for consultation, the transport, even the consultation fees you pay are far higher than the dipstick. But if you can do the dipsticks and they can learn, everyone learns, even the uneducated. If you do the dipstick yourself and you realize protein is negative on 3 consecutive days, we just teach you how to change the doses. You saw the definitions there. So we limit how much prednisolone we give to this patient. If they can check the child's urine on 3 consecutive days, we go to remission, they start tapering the prednisolone. And then they start reducing. When you see protein popping up, then now stop reducing or go back slightly above. So I think the daily thing, even in our government setting, I think Dr. Ujo, you agree, we can still do it, except in some it's really hard. And you have to do one single urinalysis, which is provided for free. There it's harder. But when it's possible, I think we should do it. It helps reduce the exposure to prednisolone. Then I'll go to the diuretics. Yeah, Dr. Kansime, that's a challenge. First, diuretics, in fact, the children with nephrotic syndrome have no volume in their vessels. That forcing that the kidney not passing urine is trying to save the limited volume that they have. Forcing them to pass urine, you're causing hypovolemia, and that's when creatinine starts changing and you get side effects of hyponatremia from the Lasix. The best would be, and again, resources limit us, it would be to give albumin, then with Lasix. And when that is possible, that's what we should do. But sometimes it's really hard, and we also have to give the Lasix. But I think the best is to give it with caution, because this is not the problem that's going to solve this child. And sometimes the children are very swollen, but they are walking around and playing. So the best is leave them. And then treat the nephrotic syndrome. Nephrotic syndrome, when we give the right dose of prednisolone, tends to disappear in 5 days, 1 week, swelling disappears, and the pain doesn't pain. Then probably quickly to go to SGLT2. I think you have more information about SGLT2, especially the adult nephrologists, than us. It's hard to know whether we should try using them in other disease states. The only study that's, I think, upcoming, which I talked about yesterday, which is in children and in other disease states, is the one that's in Germany. It's called, I think, Double Protect. It's enrolling and taking on children with Alport syndrome to see if when they give them SGLT2, it prevents proteinuria. So, but the question probably would be, what about an IgA or other diseases or nephrotic syndrome that's resistant? I also don't know. But I think maybe as more studies go on and more information is got, SGLT2 will be also applicable in children. Thank you.
Thank you so much for the questions. I had some questions. One of them was about the water analysis. From my experience and from the center where I come from, it is usually done once every quarter, and this is part of the quality improvement. But sometimes it is done more often than that, especially when we think there are some patients who are coming and they have got infections, and we think maybe partly this is because of the water system that we are using. And so it can be done more than once a quarter. And oftentimes the analysis that we do is in a microbiology. We focus on the microbiological part of it, and rarely have about the heavy metals. And so for that matter, go beyond to look at water analysis beyond, microbiology. The other part was about how many sessions. I did not get the question very well. I missed part of it, but specific for the patients that were enrolled in our study, these were patients who had 2 sessions per week. Like I said, we have very few patients. I think we had like 3 or 4 patients who had 3 sessions. And still, these are patients who you think they're on chronic dialysis. Down the road, they are getting more sick, and if you need to do maybe much more sessions than you should be doing 2 times a week. And so that surely from our practice, 2 sessions, those were the patients, and that has been the standard of care for most of our patients. Whether the heavy metals could affect the hemodialysis adequacy, it's hard for me to answer, and maybe the reason why we recommend that we could do some other studies to try and find out whether there are other factors beyond what we have that could be affecting hemodialysis adequacy. Thank you.
Yeah, thank you, Dr. Javira, for the questions. I think about the water analysis, for the specific study that I presented, I would say that this wasn't considered, and that presents us with limitations of using secondary data. My good friend, Dr. Daniel Chigundu, is the custodian of that data, and at the time when I was doing it, I think that was not considered. The other limitation that is not documented basically is being a student is not easy, because you have limitations in time, but also resources. You're racing against state deadlines, so you want to do something that is within the limits. So this is something we could pursue. Since we are set out to do more studies, I think the studies that we've presented today could be like the baselines, or it could be like the starting points for maybe other studies. Thank you very much.
Yeah, thank you so much. Just coming in to make a comment on adequacy. One of the major roles of a renal nurse or dialysis nurse is to monitor the patient. Not only the patient, but also the machine. And so when the water quality is not as preset, it gives us an alarm, an alert. So you'd want to go and check in the water treatment plant what is happening over there. So your findings, you actually report them. So the challenge that comes in here is mainly institution-based, because you have to report to the technicians who have to come and put right things concerning water purification. And that will come with call so and so, this is missing. So you have had cases when looking at the study site, patients in Chui are not dialyzing. Why? Because the treatment plant is, something has to be done, or Mlago, or so. But then in our setting as Uganda, that's why UKF should come up for advocacy, is that such a patient, you tell him, our water is not pure for a session today. Maybe hold on or go to a private setting to get adequate dialysis. They can't afford it. So there is data that shows if your water analysis is not, there are heavy metals in your water, definitely you will not have adequate dialysis.
Yeah, thank you very much, Professor Kalesubura, for the comments, the positive comments and feedback that you have given. I think we shall talk to Dr. Bate and Dr. Aujo, who are the seniors in this field, to make sure that at least we come up with programs which can make fluids available in this country. Because importing the fluids from out actually is one of the most limitation for peritoneal dialysis everywhere. So if we can make the fluids within the country, there are now better peritoneal recyclers. I think Baxter has worked on one called the Clariot. It's actually very good, automated. So I think if we have the fluids available in the country, we should be able to also have those machines. And we will be able to do both acute and chronic peritoneal dialysis. I think this is possible, but we also need the will and the people up there to be able to support. Thank you very much.
So there was just one burning question from Dr. Lukoma, and then we'll have closing remarks from Professor Karisula and Dr. Sekasamvu.
Okay. This is a question for Dr. Chigundu. First of all, Dr. Chigundu, thank you for your excellent presentation. Being my senior, I wish I had your presentation before, struggling with Cecil's and Harrison's to understand these diagnoses. You made it so simple and very clear. I had just a couple of questions about the diagnostic capacity, and this maybe will help other physicians and the general doctors as well. Which centers are we able to do the renal biopsy in, and what are the costs attached with it? And then after that biopsy, where is the pathology sent, and what are the approximate costs? And then the same thing for the immunofluorescence. Is it available within Uganda, and approximate costs to the patient?
So for extensive workup, including multiple light microscopy stains and IF, we've been sending some samples to India. We've worked with 2 labs. One is called something NEFCOR lab. It's lab on Buganda Road. The name has skipped, but Metropolis. Yeah, Metropolis, and then Star is the agent of the other one. And the costs up to 850,000, 600 for one, and 850,000 for the other. In terms of getting the biopsy done, well, we have nephrologists who do them in Zambia. I've ventured into them myself. I do them. We also have interventional radiologists who are coming in, and they're very eager to take that space. I think we have 2 or 3 cohorts in training now.
Yeah, just a supplement.
Yeah, so I'm just supplementing. So the actual cost, as you've heard from Dr. Chigundu, those would be in private. In Mbara, we are also we have, obviously, our pathologist was trained. He can comfortably read the light, but he also can read IF. I have an IF microscope, but I'm not using it yet, but very soon we should be able to use it. And the plan is, and hopefully really, that if it becomes functional, we should be able to get it done, I don't know at how much, but probably for free for the start. And this is really because of the study that we are going to be doing. So just keep us in your prayers.
We have started. Okay. Dr. Sekasamvu, you can give closing remarks.
Robert, you wanted to say something?
Yeah, I think my mentor will wrap up. My comment was about the standard of dialysis. The standard of dialysis can never be 2 times a week. And I'm happy that the nurses are here. Let me stand up. Dr. Bagasha did a study from Kirudu and clearly showed that if you do dialysis once or twice a week and other people don't do dialysis, the results are the same. The quality of life is actually worse in the people who do dialysis. I know we have inadequacies, but let's not normalize abnormalities. When you are counseling people as nurses, it's like giving antimalarials. They are given for 3 days. The dialysis is the same. We do it 3 times a week. When we are initiating, because we fear the disequilibrium syndrome and all those complications, we do for less time, less flows. But the standard of dialysis is 3 times a week. So let's make that clear. Let's try to advocate for it. The resources might be limited, but the quality of dialysis should not be compromised. So that's very, very important. We can look at how to implement, but now when you say the standard of care is 2 times, that is very, very worrying because it's not a standard. I just wanted to say that and make it very, very clear. We could have a debate later, but that's what I wanted to say. The other comment is to my senior, Rose. Free things are very expensive. So please, do these things at minimal cost for sustainability. Because if you are doing a study, it is going to end, and if you put in the mindset, unfortunately, of Ugandans, free things. I have an organization, it's called Access. I gave free services for about 10 years. When COVID came and we had no money, and we tried to charge them, they said that the Bazungu gave us money, and we want to cheat them. So when you start things, begin with the end in mind. Put them at minimal cost so that when you are gone, they can be sustainable. That is leadership. So please note that. If people are in a study, you write it different, but always let them know that someone is paying that bill. This is why we are not giving free dialysis, because it's simply not sustainable. This is hard talk, but it's also reality. I thank you.
Dr. Sekasav, I have a question and then comment. Dr. Bate, steroid resistant, 8 weeks, Abuja African nephrologist, then late responder, 6 weeks. I don't know whether the Africans have a late responder definition of their own. Otherwise, if you have a steroid resistant 8 weeks for the African, then you can't diagnose the late responder. It becomes very difficult. That is a question or a discussion for another day. But generally what I want to say is that the presentations were good, and the presenters are fantastic, and the knowledge dissemination is good. However, I think we should have organized presentation of papers and lectures intermixed, because some papers they have got some element of knowledge dissemination, but they create a little bit of confusion. For example, the dialysis adequacy, which Professor Kaliesubla has just talked about, it was looking at solute clearance, urea clearance, and I think it was also looking at, mainly that's what it was. But in the definition of dialysis adequacy or assessment of dialysis adequacy, there are many aspects. We assess nutrition of patients. We normally use albumin as a surrogate marker. So if a patient is not well nourished, then the dialysis is not adequate. And that aspect was not assessed. Alongside albumin, we use HB. And that is why you actually found that your HB was better in patients who had better clearances. But actually that was a measure of adequacy other than the other way around, the way you presented it. And then we looked at solute clearance, which is a KT over V or urea reduction ratios. And we also look at B control in these patients. That is also part of dialysis adequacy. And like Professor Robert has, the duration is part of dialysis adequacy. So the entry point for you was that was inadequate because your patients were dialyzing, first of all, using less time than internationally recognized. But secondly, they were using the same size of membrane regardless of size of the patient. So the dialysis was not tailored to the patient. So I think we should have had, from your presentation, you should have had an aspect of a lecture of how to assess dialysis adequacy and what exactly it is. Because from this conference, the students and other people might come out of it confused with the wrong notions of how to assess dialysis adequacy. Nephrotic syndrome. Definitions were presented, but I think a little bit of emphasis on aspects that confuse clinicians need to come out. Let me talk about diuretics, which we are being asked about. We all know that in nephrotic syndrome, we have accumulation of fluid in the extracellular compartment. And the fluid in the extracellular compartment is normally in the interstitial space or in the intravascular space. And in nephrotic syndrome, it is mainly in the interstitial space. And the usual notion is that when you see a patient who is very swollen, they definitely need diuretics. But unfortunately, that's not true. A lot of these nephrotic syndrome patients are intravascularly volume depleted. And we give them diuretics, and they get AKI or ATN on top of the nephrotic syndrome that brought them in the hospital in the first place. So you find that they come in with normal creatinines and clearances, and eventually after you initiate your treatment, you find that they have gone into renal failure. And this concept doesn't seem to come out or to be understood by clinicians very well. So the clinicians need to understand that these patients might have fluid accumulation in the extracellular compartment, but the intravascular fluid, which is very important for organ perfusion, is normally reduced, and they are very prone to getting ATN when you give them diuretics. Not only are they prone to getting ATN, but they are very prone to getting side effects from diuretics. I have seen many who are deaf, and the clear reason is that they are hypoalbuminemic. And the furosemide is a protein-bound drug. So if you give them furosemide, they will have a lot of free drug floating around, and that drug is the one which is going to cause toxicity. So you have to be very careful about them. Now, for the two senior nephrologists in Mulago, Dr. Bate and Dr. Caro, I was actually thinking, because I thought I should take 3 doctors to court. Dr. Riba and Dr. Caro and Dr. Bate for malpractice. And I was debating in my mind of the 3 who to take to court. I wanted to divide them into 2 groups, Oriba in one group and these 2 in another group. And in my mind, I thought I should leave Oriba and take Dr. Caro and Dr. Bate to court for malpractice. Why take them to court? The question I have for them, what is the standard modality of renal replacement or dialysis for acute, chronic in children in Mulago Hospital? Mulago is, we call it the creme de la creme of medical training. It should be our star unit. So if you have deficiencies and you have to really improvise quite a lot, it's not nice. That means failure on your part to impress the administration and the people who are giving resources to these units to actually give you something basic or something standard to show the Oribas, and then the Oribas can probably try to modify having seen the standard. The presentations you gave us actually should be given to the administration of the hospital so that they can look into themselves, or the Ministry of Health. One of the reasons for World Kidney Day and for conferences like this is for advocacy, and we need to stamp our foot and tell them what we need. We have seen them waste a lot of resource in things that we don't need. And I think this is a wake-up call to you to emphasize upon the powers that be, to provide at least the basic for training, so that our students and other care providers in the country can come to a center of excellence where they can see where standards are being done. Dr. Oriba, you are exonerated. I think I'll take the seniors to court, but you should also prepare yourself for, to defend yourself in this court litigation case. Otherwise, apart from that, I think we are getting there. Now, heavy metal contamination of water, patient delirious, water quality issues, and so on. Do we have any dialysis technicians here? Do we have any in this conference? We don't have. We have had issues with water quality for obvious reasons. First of all, those of us who are doing dialysis, probably, I don't know, Dr. Oriba, in Gulu, which water do you use? Do you use municipal water? Do you use hospital, like rainwater? You have a well or what? Underground, eh? Because the water quality in Kampala and other municipalities is very variable. Even in a single day, you can have water vary as many as 10 times or 12 times. Because people dig holes, the pipes break, sewage goes into the pipes, water, solid materials, stones and pebbles and all this. So actually getting a proper water quality in Kampala is a nightmare. So as a result of that, in some of these units, we have actually put in secondary, we call pre-filtration filters, which we change maybe 3 days or 5 days. We change them. Of course, when you get a water treatment unit, they give you standards with it, that this filter, you change it after so many days, and some of them are computerized. But when you come here, it's a different story, because the water quality is very difficult. So because of that, the installations are made in a different way from how the Europeans or other people do it. But for the technicians, there is a tendency of what we call bypassing some of the aspects of the water treatment unit. This is in order to get the unit to run. Somebody here was saying, if the patients come, you can't tell them the water quality is bad. So what they do is they bypass some of the filters so that the machines can run. But that is very dangerous. And we should emphasize to them that that is a dangerous thing, and we should always make sure that the water goes through all the stages of filtration until we get ultra pure water for dialysis. I think those are the few comments. And the last one is that initially when we were starting to provide specialist renal care to patients, we have had a lot of baby steps, and the baby steps are not smooth. You keep having falls here, staggering here and there. And I think now it is time to perfect our practice. Those things that we have been doing badly, we should perfect them. Now we know we have dialysis, we should do it properly. We know we can do peritoneal dialysis, we should do it properly. We know we can now make proper renal diagnosis using biopsies, we should do it properly. And I haven't seen any labs here that do renal histopathology or renal diagnosis invited into this conference. So next time, we should widen our net and get all these people with whom we work to come and discuss with us. Thank you very much.
Thank you very much, Dr. Sekasamvu and everyone else that has participated in this session. I'll just have to cut it short because we are really running behind on time, and I will request us to have a working tea break. So I'll request all of us to just take the stairs up, get a cup of tea and return so that we can start the next session overlapped with our tea break. Thank you.
People who have gone for the tea break, please come back quickly. We are running out of time. It's supposed to be a working tea break. Come down with your cup of tea so that we can start. We are starting in the next 5 minutes, so get your cup of tea quickly and come down. We are starting the next session. In the interest of time, those of us who are not yet here, we are starting in the next minute. I encourage you to visit the farmer stands during the lunch break. It is now 12 o'clock, and on our schedule we should have started already and probably edging towards the end of this session. I would like now to, first of all, introduce our first presenter, Dr. Daniel Chigundu. You have already seen Dr. Daniel Chigundu earlier in the day making a presentation on nephritis or nephritic syndrome. And Dr. Daniel Chigundu is a nephrologist. He has mentored many of you. He works as a consultant nephrologist at Chirudu Hospital, and he also helps to supervise and run the nephrology service at Mengo Hospital. The other aspects of Dr. Chigundu have really been introduced. Dr. Chigundu is going to talk to us about anemia and chronic diseases and the options we have for that problem today. Dr. Chigundu.
Put this one here. Thank you very much, Dr. Sekasambu, for the kind introduction. And I'm grateful to the Uganda Kidney Foundation for giving me a second opportunity to talk to you this morning. And this talk on anemia and chronic kidney disease is sponsored by Oncofarm Specialty Pharmacy through their brand Himax. So this chronic kidney disease, as we all know, and has probably been said over and over, refers to abnormalities of kidney structure or function that are present for over 3 months with implications for health, determined through either structural or functional assessment. And all people with chronic kidney disease are represented on this heat map. And about anemia, anemia is defined variously for different populations, but the essence is that there should be an adequate red cell mass to provide oxygen to the body. So these are WHO cutoffs, and you can see that they vary by child or adult status. And for adults, they vary by whether one is a woman or a man. In chronic kidney disease, the prevalence of anemia increases by stage. This data is from South Africa, and you can see in the gold row there, the prevalence will rise from 23% in stage 2 to over 90% in stage 5. This was a cohort of patients attending an outpatient clinic. We also know that anemia in chronic kidney disease predicts mortality. And you can see that for the lower HP here, the hazard ratio for mortality really goes up. And for the people between 11 and 12, they are the best. And then the hazard ratio for mortality starts to go up again after, if the HB rises beyond 12. And we know that this is for many reasons. We know that there is a lack of erythropoietin, but we also know that there are changes in iron metabolism, and there may be absolute iron deficiency, or there may be iron deficient erythropoiesis because of iron sequestration in the reticular endothelial system and poor absorption driven by hepcidin. And so when we think about a patient with CKD, with anemia, first of all, even when it's not in our faces, we may need to screen all patients. We need to screen all patients with CKD for anemia. And the frequency of this screening should increase with GFR stage. As we have seen, it's more common with advanced stages. So at least annually for the people with CKD3, and by the time you reach CKD5, quite often it's monthly or every 3 months. And it should, when you first encounter anemia and CKD, you should do a broad evaluation, the same as you have in a standard textbook for how to assess anemia, because just because they have CKD does not limit the scope of causes that they could have. So there could still be causes that contribute to inadequate red cell production or increased RBC destruction, but also we know that RBC lifespan is reduced. So the evaluation beyond the CBC and HP will typically includes an assessment of iron status, but also other causes that could exist in the patient. Iron status is evaluated through ferritin and transferrin, but in our setting also on the CBC, you will be able to see low MCV and low MCHC. The percentage of hypochromic RBCs might increase in use, although it's been in the wings for many years, but it hasn't quite come to full use. Specifically regarding iron stores, low ferritin below 100 indicates absolute iron deficiency. Very high ferritins could be misleading. They don't entirely mean adequate iron stores. They could be a response to inflammation. And so the second marker helps us to fine-tune that. So if one has got an adequate ferritin, we are looking at the transferrin saturation, and if it's below 20, it tells us that there's iron deficiency. Now, jumping straight to the treatments, as guided by the presentation title, what therapies do we have for anemia and CKD? It's still 4 foundational therapies, and the chronological order of how they've gained importance over the years in the treatment of anemia in CKD. And the oldest in the 70s and early 80s, what was available was largely blood transfusion. I know that some of our patients are still stuck in this era. They want to book blood before they show up, and this is something that needs to be nipped in the bud. So transfusion is not a standalone plan. It should fit in an overall anemia management plan, and it's indicated for severe symptomatic anemia. It's also indicated if, for some reason, excessive risks are associated with the alternatives. And in general, since we consider every patient as a potential transplant candidate, we want to minimize blood transfusions to them. And finally, irradiation is not foolproof against alloimmunization. So you need to weigh and individualize the decision. The second in chronology was the erythropoiesis stimulating agents that came in towards the end of the 80s. Yeah? It's a revolutionary product from the 80s, like other revolutionaries you may know. And they reduced the requirement for blood transfusion, improved quality of life, giving better energy and physical function. And they work by stimulating the EPO receptor on the RBC precursors, promoting their maturation. And in the absence of such stimulation, a lot of the precursors don't reach maturity and don't help erythropoiesis. So the indications for people who have got chronic kidney disease with an HB below 10, with all causes of correctable causes of anemia addressed, you should use erythropoietin. Contraindications: hypertension, pure red cell aplasia, or allergic reactions. And the initial prescription was 3 times a week, but recognizing that more than the dialysis population is using EPO, we have modified plans. This is from the upcoming 2025 KDIGO anemia guideline, and the guidance includes options to even use big doses such as 10,000 units every 2 weeks or 4,000 units weekly. Lessons from the early trials were that targeting normal HB did not reduce mortality. In fact, it seemed to worsen mortality, especially cardiovascular mortality. And the drive was partly blamed on higher EPO uses. So this forced the community to look for ways to mitigate the overall EPO dose, including the use of iron. And over time, we have learned, both in the dialysis population and the non-dialysis population, two things: that we may need to target a high ferritin and take a proactive approach to improve iron deficiency to mitigate EPO use. We can see here that IV iron fares better than, the high-dose IV iron fares better than oral iron in the bottom line, but still the second message from this slide is that there's still a benefit from oral iron in non-dialysis patients. And we also have newer iron formulations that should improve tolerance and should also improve bioavailability, including things like liposomal iron that are not yet in our market. Finally, the newest kid on the block are the HIF stabilizers that promote native erythropoiesis. So it turns out, even for those who have no kidney function or have had nephrectomies, there's still EPO production that can be stimulated from the liver. So these are great addition. They are also oral, and they have been demonstrated to be non-inferior to EPO, but they are new, and so there are cautions. The cautions are, in case of active malignancy, we can't use them. We don't know what they do to ADPKD, and there are concerns about the use of seizures, and also there are concerns about thrombotic events. I'm winding up. And market, they share the same indication. We don't know the optimal time to use them, but we know a sensible way to start is to use them similar to EPO. And this is a guideline that's out for public review and public comments. So we haven't used it in its entirety because it's going to be modified by what feedback the public gives. Once again, this is sponsored by HEMAX, and we shall take questions at the end of the overall session. Okay, so that's it.
Thank you very much, Dr. Dan Chigundu. Now I'm going to invite the other Chigundu. Dr. Brian Chigundu. Dr. Brian Chigundu is a physician and a cardiologist, and he's looking after our hearts in Uganda Heart Institute. He's going to talk about SGLT2 inhibitors and in cardiorenal comorbidities. Dr. Chigundu, unfortunately, you have 10 minutes in which to present, and your time starts now.
Good afternoon, everyone. I'm so glad to be here. Because I have little time to present, I'll go straight. My talk is short but complex, but I'm sure it's a revision to most of you. So we know that type 2 diabetes is a cardiovascular disease, and I'll show you why. If you look at the data from Sweden, in Sweden, when you're born, they taking your data So we usually use their data to demonstrate a few things. So the curves, I'm going to use mainly diagrams so that I save a bit of time. But you can see that if you're diabetic, you're more likely to die from CVD. And of course, the major killers if you're diabetic is heart failure and myocardial infarction. Also, to just, it's a slide to almost say the same, that when you're diabetic, you live shorter, and also you die faster when you're diabetic compared to the others that are not diabetic. So we also have discovered that diabetes is very common in cardiac patients. Almost 60% of patients that present with myocardial infarction have impaired glucose or they are diabetic. This is basically, it's the same thing, just in diagrams, that 60% of people who present in the emergency with heart disease have a problem with their sugar. And we can see that the ones that have a problem with their sugar are more likely to get events than the ones that are euglycemic. This is probably the same, so I'll skip it. Probably similar, to emphasize that when you're diabetic, you're more likely to get CVD, and you're more likely to die earlier than those that are non-diabetic if you don't treat it well. So in the recent years, we used to treat HbA1c, but now from 2015, we don't only treat HbA1c in diabetes. We know we can change the outcomes by reducing MACE. MACE is the hard endpoints. MI, death, stroke. And this is a tiny diagram to show you where diabetes treatment has come from. Before 1922, they were only using diet, so there were no drugs. Later, insulin came, and then drugs came. And then in 2013, the DPP-4 inhibitors came into the market, and they struggled to see if they go beyond HbA1c and failed. But in 2015 and 16, the SGLT2 inhibitors and the GLP-1 agonists came into play, and this demonstrated that we are now treating beyond HbA1c. There are many trials, but there are mainly 10 that we probably summarize in this presentation to show you how now we can treat diabetes and think about ending the adverse endpoints. So the drug that I'm actually going to focus on is SGLT2 inhibitor. And it's funny that the drug works in the kidney, but now we know we can use it with heart failure and other things. Initially, it was probably by accident that in 2014, while they were assessing it for diabetes, they found that a certain population of people who used it, they suffered from less heart failure events. So then the trial came in to assess it for treatment of heart failure. So basically, a molecular level, here, the proximal tubule, you reabsorb about 120 grams of glucose a day. So when you inhibit that absorption, you realize that, common sense, you lose a lot of glucose, so your glucose level should be low. But however, as the glucose goes through, you also take sodium and take water. So that's how the drug works at the molecular level. Some of the effects we could not explain, but we speculate. But on the right side, the effects that come when you use such a drug. So these are just the trials that came, following each other, 2015, 2016, and 2018. And you can see that they were trying to confirm that we can actually use this drug for CV death prevention rather than just diabetes. And you can see that among these patients, a few of them had a GFR of less than 60. So that's why we were really focusing on the kidneys. These are the main drugs, and this is latest. We have the GLP-1 and the SGLT2 inhibitors. Now, you'll see later the SGLT2 inhibitors are actually more kidney friendly, and the outcomes are better for renal protection than the GLP-1. And I'll show you that. In the interest of time, I'll skip this. So in these trials, the most important things that actually we saw was the renal events were much less. You can see on the extreme end that the relative risk reduction was over 39% for Empareg, over 40%, and so we realized that the main thing that these drugs are doing is reduction of heart failure and also reduction of the renal events. The hard endpoints were significant statistically, but not as good as prevention of heart failure and renal events. So this is a summary of what I've been saying. You can see that renal protection was over 45%, and then followed by heart failure by about 31%, and the MACE, it's just about 11%. So we know that the hard endpoints we benefit, but it's mainly heart failure and renal events. So I think I'll skip this, but the summary, this shows that when you use SGLT2 inhibitors are mainly when you have patients with heart failure and CKD. GLP-1 is stronger with hard endpoints, MIs, death, and stroke. So if you're looking at that, you probably go to GLP-1, but if you have patients who have coexisting renal and heart failure, you're more on the money when you go for an SGLT2 inhibitors. This changed after these drugs came in the market, but of course we all know when you do an HbA1c, you start treating lifestyle modification, you start with metformin, and then you can bring in these drugs depending on at the level where you are. This basically is heart failure really. We can see over the years we have moving from ACE inhibitors, beta blockers, ANIs, and now in 2020 the SGLT2 inhibitors have come in play. So I won't waste so much time on this, but we basically know that they have come in play for treatment of heart failure because we have evidence and we have good outcomes. This is probably a repetition. Heart failure, we are very strong on the SGLT2 inhibitors because of evidence and because we have used them in practice and we actually get good outcomes. Now, this is a summary of the studies. I will skip it, but we can see that we do very well with these drugs with heart failure from evidence and clinical practice. And in fact, the guidelines have changed that we are now using them as class 1A because of these studies and the registries. So this is the DAPA-HF trial. I'll skip it. You read about it. I'll share my slides, but it shows when you use these drugs in heart failure, primary endpoints, CV death, hospitalization, and urgent heart failure visits are less. A reduction of about 26% is massive. This is a new trial that was used in patients with worsening heart failure and diabetes. We also see that they do better. Up to, I think 2 years ago, we didn't have any treatment for heart failure preserved ejection fraction. Now we have evidence to show that these drugs actually work. So we have two big trials that came out about 2 years ago, Emperor preserved, that show number to treat is only 31, which means we've never had such evidence. So these drugs can be used in HFpEF. We also have the Deliver, which also confirmed that now we have treatment for heart failure preserved ejection fraction. So the kidneys, there is data there, and I'll skip and go to most of the things I have said anyway. This is the first trial for patients with CKD, with or without diabetes. So you can see that the GFR in the inclusion criteria was between 25 and 75. So there are those who are less than 60. And you can see the outcomes are actually desirable. And basically what they were measuring was more than 50% reduction in GFR, progression to end-stage kidney disease, renal and CV death. And you can see that the number needed to treat was actually 19. And this data is compared to the other data with these drugs in heart failure. So we know that patients with GFR above 25, and we can safely use these drugs because they help to to reduce these events that we really try to fight so much against. This trial was stopped early because of the overwhelming efficacy. So those that needed data for the kidneys, there is the data. This is the summary of what's there. You know, what they measured really was albumin creatinine ratio and the GFR. And you can see that these drugs performed better than the placebo in terms of events. This is the same. It just shows you that the drug does better. And you can see the p-value is 0.00000028. So which means that the data is credible. This is the same thing for secondary outcome. This is just to compare that DAPA-CKD with the other data of where the drug was used. And you can see that the data there in kidney patients is as good in terms of outcomes as the other studies for these drugs in heart failure. To summarize, I mean, these drugs have side effects, of course, and as clinicians, we always have, we must know the side effects, and sometimes we must speak to our patients about them before they are started on these agents. Of course, the commonest is the genital infections. They are very common. In fact, you should tell your patients, because almost 70% they complain of these infections when they start the drug. Common sense. Too much sugar in the urine, you get infection. So they usually, within the first 6 to 12 weeks, these infections somehow they don't recur. So you shouldn't stop these patients from using these agents. Also, you need to remember that those that are not on insulin, they are prone to DKA. So when they present to you in a funny way and they are not on insulin, think about DKA as a side effect. The other things we have not been able to explain is amputations and fractures. But when you look at the data from the studies that I presented in detail, the rate of amputations was similar in those that had the intervention and those that had placebo. So we still don't figure out why. And for the GLP-1s, it's mainly GI symptoms, nausea, vomiting. The heart rate may raise. Some may get a few gallstones because they are losing weight. I think I will stop here because of time. I had so much to say, but I will stop here. Thank you very much. I was asked to come and present by Microlabs, so I was asked to flash that slide. Thank you very much.
Thank you very much, Dr. Brian Chigundu. Professor Kalisubula, I don't know whether you can present in 10 minutes. What? 40? Ah, no, it's not possible. Okay, I'm going to give you 15 to 20 minutes. You can skip some of the slides. Huh?
We struggled with the president, but it's okay, I will.
Okay.
The good thing is the cardiologist has covered.
Don't present in 40 minutes.
No, I'm going to present
okay.
in 20 minutes.
Okay.
But that's very unfair, Mentor. All right, thank you very much. So this talk is sponsored by Eminent, and so that's the conflict I have to declare. And they have 2 drugs, Osema, which I'm going to talk about, and also the Canopus, Nerenon. So I'm going to talk about the cardiovascular kidney metabolic. It's very good to talk about after cardiologist. And we are not arguing about Lasix, but serious business. So we are just going to complement each other. This is what I'd prepared, but when the mentor says you go slow, you have to slow down. So I think we know that the leading causes of death worldwide are these. It's the hypertension, smoking, but you can see that kidney disease, depending on which year you are looking at it, it's the 7th leading cause of death. Hypertension is very common. About 1.5 billion expected to have it this year. Uganda is not spared. In some areas, we have 34% prevalence. You can look at where you come from. I don't know what the people from the north eat, but they seem to be protected. And diabetes is a big problem. I'm going to go over this. Dr. Rumu helped me with this. Obesity is another problem. Just recently, they shared that actually up to 19% of young kids going to secondary schools might actually have obesity. So it's beginning in early childhood. 1 in 8 people have obesity. You look at your table. If you are the 8th, do your BMI. Now I come to the kidney. Of course, many of you have heard these slides. It's estimated that over 850 million people are living with kidney disease. The problem is 90% of people with kidney disease don't know that they have it. And 70% of the people who have kidney disease have no symptoms. So if there is a key message here is that for kidney disease, you have to look for it. And even those who know they are not on the right treatment, that's what Professor Lex is trying to tell us there. This slide, I'm going to skip it painfully, but I've shared it on several occasions and you can pick it up, but it speaks to the peculiarities of the low and middle income countries. When we talk about diabetes, hypertension, and obesity, that is from the West. But when we come home here, you've heard the previous speakers, the Oribas, we have infections, we have sickle cells, we have HIV, we have APOL1, we have childhood malnutrition, all these things play into the CKD. The key thing here again is that we can reverse these problems. That's why you see those arrows going in different directions. You can do a lot to reverse kidney disease. Maybe that's the key message. This one, heat map, again, I won't talk about it. I thought maybe Dr. Chigundu will talk about it. But when we are determining kidney disease, we use the glomerular filtration rate and we grade it accordingly. And then we cannot complete kidney disease diagnosis without looking at the albumin. Even if you just do a dipstick, you would know where we are. Because using those, we are able to stage our people. We know when to refine the videos. And then lastly, we have to establish the cause. As Dr. Chigunda and the rest were telling you, if you find GN, what is causing it? Again, I won't do that. This is a study we did, and we show that people present to us very late. This was done in Mulago by our postgraduate, Babua, and people present very late. End stage, 52%, they come to the renal clinic with end stage. And we have evidence that kidney disease kills. These are 50,000 individuals we looked at in Mulago over a period of 4 years. And kidney disease was the 5th cause of death among those who are dying from Mulago. So we know, and we have the evidence that kidney disease kills. Then Dr. Kansiime herself for her master's showed that those in dialysis, they have very much cardiovascular disease. And we know that actually what kills people in dialysis units is not actually the kidney. It is usually the cardiovascular risk, and second is infection. The third cause is actually the kidney. This is the crux of the talk. And I'm happy Dr. Brian Chigundu. I think the Chigundus are very bright. Chigundu Dan, Chigundu Brian, cardiology, nephrology. So Dr. Brian has done a very good job. And this is the cardiovascular kidney metabolic syndrome. It occurs in stages, and it begins with the fats. So the fat metabolism goes into trouble. Then you end up into the metabolic risks. Then now stage 3, you are having complications. And these are cardiovascular and largely renal. And then when you go to stage 4, you are dealing with the complications. There is a very good paper which was written by Ndumere, and it's freely available. Please look at it. It explains this very well. So, and Dr. Brian has again talked about this. But you see, the mortality over 10 years increases with your rising GFR. when you have diabetes. So we know that diabetes increases the risk of death in kidney disease. Brian has showed you more evidence than this, but this was looked at in 1.12 million. And there is a graded mortality with any rise in GFR. I know many of you are epidemiologists, but you can see those graphs going up. I know it's not clear, but that is stage 1 going to stage 5. The mortality can increase by up to 16 times when your GFR drops below 16. Cardiovascular mortality. In fact, kidney failure is a greater risk than smoking. It's a greater risk than even diabetes. Once you end into the kidney failure, your risk of cardiovascular death totally goes up. Of course, you have to control that is hypertension and diabetes, which could have led to the kidney disease in the first place. And then, the ejection fraction talked about by the cardiologist. The lower your ejection fraction, the higher your risk of death when your kidney function is lower. So I think with those slides, I've convinced you of the cardiometabolic syndrome and how these diseases interact. If Dr. Sekasamv is happy, I'm happy. You should have to time me, because you warn me 10 minutes so that I stop. So this is a very important slide of how we treat people in nephrology, irrespective of the cause, by the way. We have to look at lifestyle. We have to stop smoking. We have to look at the RAS inhibition. We have to do blood pressure control, and our target is 130/80 and below. I see that most of the people here on dialysis never meet that dialysis. I'm happy Professor Sekasamv talked about this, the adequacy of dialysis. Then statins, we don't use those in everyone. Then for those who have glucose, we should control it, SGL2, GLP-1s, and of course we have the dialysis or end-stage specific treatments, metabolic, transplant, and what? A health plate. This one is a Ugandan one. Don't fill your plate with posho. Don't fill your plate with rice. Have half of it with fruits and vegetables. This is a Ugandan plate. You see the avocado. That's important. And there's a glass of water there. Water is life. Always take water. These others, they are very important, by the way, but we always underemphasize them. So I put them here because they are what we can all do. It costs nothing to stop tobacco. It costs nothing to reduce your weight unless you are rich and you want to use our OSEMA. We can do that for you, as I'll show you. It costs nothing to reduce salt intake. And these are the key risk factors. This is what some of you have not heard. Those who have heard me talking, this is what I advocate for. We know that now sitting is the new smoking. And I know Sek has taken my time, but it's the mentor, I have to obey. But you see here, we use about 7-8 hours a day seated. Like at this conference, you go from home, you wake up, you sit, you eat breakfast, you go in the traffic jam. From the traffic jam, you go to your office, you sit down. Then as you go for lunch, you go downstairs, you sit down. As you are going home, you sit down. When you reach home, you watch TV, you sit down. So in the year, you sit 116 days. Okay? So just sitting, think about that as you reflect. Exercise, I won't talk about it, but it's very important. This exercise should be purposeful, not these things of once in a while you give it. It should be 30 minutes minimum. Continuous. You don't do 5 and wait in the evening because it is physiological. You have to stress your body. But you know I have 20 minutes, so I can't tell you more. So these are the pillars of what we are using to treat and slow progression of kidney disease. Luckily, doctors talked about many of these. So we have the pillar of GLP-1. This is especially when you have diabetes. We have the RAS inhibition. Then we have the SGL2 inhibitors. Dr. Makang asked me to talk about SGL2 inhibitors in detail, but my senior has given me less time. I won't do it. Then the other one is phenylalanine. Those are the two I'm going to talk about. So this is the evidence. when you lower blood pressure, our patients do much better. I know Dan is an epidemiologist, Ms. Egole is an epidemiologist. So we use SE inhibitors, and the evidence, you see all these bars, they are all, for the ease of understanding, when these bars are this side, the drug is very safe. When they are this side, the benefit is minimal. You can see all of them are here on the different studies. So SCE inhibitors and ARBs are very, very good when used properly in kidney disease, no question. This is a meta-analysis that looked at the efficacy of the drugs the cardiologists love very much and what happens in end-stage kidney disease. Again, you see that we are leaning more on the left side, meaning these drugs are very beneficial. Sometimes when someone has a disease and they also have a kidney disease, instead of changing the valsartan sacubitril to SCE, you use that one. But of course you have to watch the potassium 10 minutes. Okay. All right. So I think this has been talked about by Brian. I won't go into it. This is your slide, Dr. Javira, the one you asked for. But let me just say a little about it. You remember the doctor was saying, Brian said, this thing was made in the kidney, but somehow, you know the cardiologists are very smart. They always take over everything, and there are many. This drug was for diabetologists to control the sugar, but because of what happens to the thyroidine they caused death. So the cardiologist said, before you start any new drug, make sure the heart is safe. So as they were trying to see the security of this SGL2, the cardiologists survived more. The hearts were better. Then the cardiologist took over the drug. The diabetologist tried to scream. Then the nephrologist came in, and now the nephrologist are actually the stars of the drug. Almost everyone should have SGL2 inhibitor, unless it's contraindicated, and that's the message here. But it acts through that SGL2. You know the kidney reabsorbs all the sugar through that transporter, 100% in the proximal tubule. But so when you block it, the sugar will go down. But these drugs do much more than that. But Dr. Sekasam said, I have these few minutes. So this is the evidence. Again, you can see the lines. For simplicity, they are all on the left. So these are studies you saw. Actually, the cardiologist talked about all of these. They are all on the left. This usually never happens, and trials are very expensive. They cost billions of money. So this is evidence you can use safely, because sometimes the pharmacists play tricks. This slide was shown to you, SGL2. Let me move. Now, how many minutes? 7 minutes. So this is a very good trial. It's called the FLOW trial. It looked at finerenone. Finerenone is like spironolactone. It's a mineralocorticoid receptor antagonist, but it's non-steroidal in that it causes less side effects. They looked at these individuals who had CKD and diabetes, and this was a very fine trial. It was done in 18 different countries, and they gave some people finerenone when they already had the other treatments, and the others were on placebo. And now I'm talking to my colleague, Dr. Chigundu. I think you should bring this molecule to Chirudu, and Bagasha should take it to Mulago. And we have it here, Canopas. It is now cheaper because the originals, but let's go to the results anyway. So they followed these individuals for 3 years. This trial was stopped prematurely. When the safety board looked, he said, this is too good. Then they said, don't continue disturbing people. And basically, it reduced mortality, the MACE went down, the starting of dialysis was much lower, the decline in renal function was much better. So this drug actually has already received approval by the FDA for use in diabetics who have chronic kidney disease. So how do you dose it? Normally for us, we give 10 milligrams for a GFR greater For a GFR greater than 60, they give 20, but normally we use 10 because most of our patients are late. So you have to watch out for the potassium. It's just like you use SE inhibitors. You really have to watch for the potassium and make sure that if it goes above 5.5, you stop this drug for 72 hours, then you reevaluate. So that's why for us we always use smaller doses, because our people cannot usually come back. Some are coming from Masaka, others are coming from very far. So that is Canopus for you, which is available in Uganda by Eminent. Now, this is the drug that everyone loves. I mean, nephrology is really exciting. We've never been at a place like this. We are always saying, give SE inhibitor, it's not working, proteinuria, Simanya, don't eat meat. But now we have these drugs, and they can slow progression. So this is a study which looked at individuals, again with CKD and type 2 DM. It was done, actually I chaired this meeting at the ISN when Professor Tato was giving this talk. This study also followed up individuals for about 3 years, and they divided them, they were randomized. So this semaglutide, what did it do? Doctor talked about number needed to treat. To prevent the primary outcome, which was progression of kidney disease to dialysis, transplantation, or a decline in GFR of 50%, which we use as a surrogate as nephrologists, the number needed to treat was 20. You heard Dr. talking about a number to treat of 39, and he said they've never seen that. What this means, you treat 20 people to get a benefit. If you treat 100 people and you get a benefit of 1, that's a very good drug. But here the number needed to treat, prevent people from going to dialysis when they have diabetes was 20. The number needed to prevent major cardiovascular events was 45. And remember, these people were already on the usual treatments, so this is add-on to. Then to prevent death from all cause, a drug works when it prevents death, because no one wants to die. If your drug, you remember the COVID times, they would say one person did not die in 15,000. Then they will say, let us use this drug. So here, the number needed to treat to stop death is 39. So this is how the drug works, but Dr. Sekasamvu, as my senior, my mentor, so it can help the brain, it can help the heart, the kidneys, the metabolic syndrome. You remember the fat where all the problems start. The liver, it decreases your glucose. It makes you less hungry. It helps your tummy to empty slowly. Gastric emptying is slowed. Decreases motility. It can even help ulcers because it decreases acid secretion. So this thing can actually be very good. And it goes to the pancreas to help the diabetes. But the key organs of today are actually the heart. It decreases inflammation, decreases oxidative stress, and also inhibits the RAS. In the kidney, it causes natriuresis. It causes diuresis, inhibits inflammation, oxidative stress, and also inhibits the RAS. So this GLP-1 is really a good drug. I borrowed this slide from Dr. Danny's mentor, Adera. She gave the talk. I listened to the talk and I copied this slide. Okay? Now, this is how we use this drug basically. It reduces cardiovascular events. I've already told you that. Its major side effect is actually the nausea and vomiting. A little bit of reaction to the injection. It is injectable. We have it here. It is Osema, thanks to Eminent. It is injected once a week, unlike the diabetes doses. It reduces cardiovascular risk. Of course, it has been made mainly for weight reduction. I have rich guys now flocking my office. We want to lose weight. Of course, I'm very careful. But of course, when you are using this drug, you have to start at a low dose, usually 0.25 milligrams, okay? And then you keep stepping up slowly as the person tolerates. In this trial, they used 1 milligram every week. It was the maximum dose. But if you see anyone has developed the GI symptoms, you can actually reduce the dose. And these drugs are here with us. These are the 4 pillars. Now, coming closer to you, we have Osema, we have Canopus, we have Telvas. Okay, I know I try to be inclusive, but I first catered to my sponsor. Then we have all these other good drugs, the dabigatran, the Foxgar, the Dapsine, as has been shared. So you have no excuse not to manage kidney disease well. I should show you the summary. I have 0 minutes. Dr. Sekasam, give me 2 minutes. Okay. Thank you very much. The senior said yes. I hope you allow. So we have not been seated down. As the Uganda Kidney Foundation, with a few cardiologists and endocrinologists, we are developing the integrated guidelines for managing kidney disease. And these are in advanced stages. We thank the Uganda Protestant Medical Bureau, the Kidney Foundation, Health at Africa, and AstraZeneca. So these things are going to be coming to you to show you where you are going to be doing things. So if someone has hypertension in CKD, this is what we've suggested so that you are able to follow through. And if someone has diabetes, of course, studies looked at a GFR of 25, but now we've gone to 20. Actually, if the GFR is above 20, you start the SGL2 inhibitors. And if it is below 20, you don't start. But if someone is on it, you can go up to 15. And there's a trial now looking at people who are on dialysis. So I'm sure the drug will pass. But what you note here is that we've put the GLP-1s down. The Americans have put this GLP-1 up. They have put it. We changed the KDIGO to adopt them. The SGLT1 is actually up here for the what? For the KDIGO guidelines. But because of cost for us, we have put it down because of cost. But the ones we are using, the Osema, is a bit cheaper. To cater to Dr. Bagasha's interest of palliative care, our guidelines are also very comprehensive. We have the comprehensive conservative care included there so that no one is left behind, even at health center too. We've also included management of women and children so that Bate and Aujo, they were very instrumental in reviewing this, so I'm sure Dr. Aujo is going to be happy. So in summary, I've told you that hypertension, DM, and kidney disease are common, and they are increasing. They are associated with high mortality. They share the risk factors, and therefore can be prevented together. The best way to manage these 3 conditions is actually having an integrated way, because as you show, the 4 pillars can actually add all of them. And then we now have all these drugs in Uganda, and we have the local guidelines, which are still in development, to guide us on how to use this. I want to thank you very much for listening. And Dr. Sekasam for giving me 2 extra minutes out of my 40.
Thank you, Robert, for being brief. You know, this Robert here, he can talk for the whole day. So you must squeeze him so that you get the maximum out of it. But I think his presentation was succinct, and all of us have picked a thing or 2. The next presenter is Dr. Cuthbert Agalo. Cuthbert is going to talk about a common problem that we see all the time, TDF-associated kidney dysfunction. Cuthbert, you are going to talk in 10 minutes, starting now.
Let me some 2 hours. Good afternoon, or good morning, still good morning. Good afternoon, ladies and gentlemen. It's a privilege for me to be here, and I would like to convey my thanks to Dr. Gavu, who suggested to me to write an abstract, which was accepted, and I have this opportunity now. And I was also thinking, when Professor was speaking, what a daunting task it will be for a pawn to talk after a king. But that said, I'm going to present on a study titled, these are partial results, partial findings from a study titled Tenofovir disoproxil fumarate-associated kidney dysfunction among patients on antiretroviral therapy, a profiling study. I have no disclosures to make, and for this presentation, I had prepared to look at operational definitions, background methods, results, discussion, and recommendations. But I'll dwell a little more on the operational definitions. So in this study, we defined kidney tubular dysfunction, TDF-associated tubular dysfunction, as the presence of a combination of two abnormalities referable to tubular dysfunction in the absence of diabetes mellitus, hepatitis C virus, and treatment with SGLT2Is. We looked at glycosuria, hypouricemia, hypophosphatemia, proteinuria, erased serum creatinine, and urine sediment abnormalities. We also had another definition for CKD, which is consistent with everything that you've seen here today. We defined we defined chronic kidney disease as an eGFR less than 60 mils per minute per 1.73 meters squared sustained over 90 days, and albuminuria derived from dipstick, which has been alluded to earlier. And for albuminuria, we assigned, this is guided by literature, a proteinuria of nil to represent albuminuria equal to less than 30 milligrams per gram, which is equivalent to the A1 classification on the heat map. Then trace to 1 plus to represent albuminuria of 30 to 300 milligrams per gram, and then 2 plus to 4 plus above 300 milligrams per gram. The background has already been done justice to. These are figures that you've had a lot. Kidney disease is common, 850 million people with kidney disease, exceeding HIV and exceeding HIV in the last 2 decades. That has been talked about, but I want to pitch here that CKD and end-stage renal disease is actually disproportionately higher in high-risk populations, of which the HIV-positive population is very key. And among the HIV-positive population, the global prevalence has been noted to range between 4.8 to 12.3%, and this is normally influenced by the estimation equation that has been employed or the proteinuria criteria that have been used. And this heightened risk can also be due to HIVAN comorbidities, nephrotoxic drugs like TDF that we'll be looking at shortly. So as far as TDF is concerned, earlier studies had shown us or demonstrated renal safety for TDF, and this influenced the choices that were made in its use in first and second line regimen globally. However, when you look at real world experiences, TDF has been associated with progression of kidney damage, end-stage renal disease, and renal replacement therapy risk. And then this prevalence is also noted to be much higher in low-income countries, and some of the previous speakers have alluded to this. We also know that these risks influence changes in guidelines in other regions except in the WHO region, and since 2016, TAF became preferred over TDF in high-income countries. However, when you look at low-income countries, including Uganda, we still maintain TDF despite its known risks. And this underpins why this study was done, with the aim of profiling the prevalence of TDF-associated kidney dysfunction among patients on TDF-based ART in a local setting, stratified by duration of exposure to TDF. Our objectives were to determine the prevalence of kidney dysfunction among people living with HIV on TDF-based ART stratified by duration of exposure, to determine the prevalence of chronic kidney disease, stratified by duration of exposure still, and then to identify other predisposing factors. And we answered the research question that does the prevalence of TDF-associated kidney dysfunction and CKD among patients on ART increase based on duration of exposure. I'm being antagonized by the time, the time flash here. And then we also tested the null hypothesis that the presence of TDF-associated kidney dysfunction on CKD do not increase based on the duration of exposure to TDF-based ART. Our method, this was an analytical cross-sectional study design. It was based on work by Shaza, which had demonstrated an increase in proteinuria and rapid kidney dysfunction and CKD with every other year of exposure to TDF. And we stratified our patients according to, our participants according to 4 strata based on duration of exposure. This study was approved by our REC at Nsambia Hospital, and it was done at St. Francis Hospital in Zambia, which had 8,490 active patients on ART by 30th of June 2024, and 95% of these were on TDF. These were mainly adult patients on ART, and as I said, all of them were active on ART. Our sample size was 420 participants, and we obtained informed consent from every eligible participant who volunteered to participate in this study. We looked at a number of variables, which I can skip for now, but for objective 1, we measured the prevalence of all the factors I talked about in the operational definitions. I'll skip that. For inclusion, we included active patients on TDF-based ART. Those were 18 years and above, and those who were willing to give us informed consent. And we excluded all those who were not registered at Nsambia, those on SGLT2s, those with diabetes, and the other factors I've noted there. We did our sampling at 3 levels. We had a master sampling frame for all participants on TDF, and then we had a stratum-specific sampling frame. Then in the stratum-specific sampling frame, we did simple random sampling for each stratum to obtain the number of participants to include in each stratum, and a total of 420 were obtained. For the primary data, we had a questionnaire, we did clinical measurements, and we also did point of care testing, which was alluded to earlier by one of the presenters. We did random blood sugar, we did RFTs by point of care testing, and here we're using dry biochemistry, where we used finger prick blood to measure creatinine, uric acid, and urea. And then we also did urinalysis by dipstick, which was not read by the eyeball, but by a semi-automated urine analyzer. We also measured serum phosphate and looked at other factors that contribute to kidney damage. But we also looked at vitamin D, importantly, and I'll be reporting on this shortly. For secondary data, we measured BMI, EGFR, and SCR by doing calculations, and then we had other data collected from the medical records. Our statistical analysis is using STATA version 18, and this is still ongoing. And we show prevalence of kidney dysfunction here as frequencies in all participants and the 95% confidence intervals. Then we also are using chi-squares to compare the prevalence of kidney dysfunction between groups at a 5% level of significance. And we are also using modified Poisson regression models to fit prevalences of kidney dysfunction and their interactions in the separate groups. But for now, we shall present that one for sex and age. So the first table here, I won't give you a detailed summary of the baseline characteristics. I only chose the sex and age. Can I have 2-3 more minutes? Okay. And as you can see, of the 420 participants, about 60% were female, and the median age was 48.4. So the first result I'll present is the prevalence of kidney dysfunction overall, and you can see from this graph that kidney dysfunction occurred in 27.6% of our participants with a positive p-value of 0.005. And when we disaggregated it between male and female, you see that among men it was 36.6 and 23.5 for female. This graph is showing the percentage of each of the abnormalities referable to tubular dysfunction. And what you can see clearly is that the highest majority had hypouricemia. We had a few patients with glycosuria, and among these, we had one patient who had full Fanconi syndrome undiagnosed before they got into the study. We also had a number with urine sediment and hypophosphatemia, according to the values presented there. I'll skip this, but these were some of the images of the urine sediment abnormalities that we saw. You can look at those at a later time. Then thirdly, we present the percentage of the of the number of abnormalities referable to tubular dysfunction by gender, just disaggregating the previous data that I showed. And as you can see, the majority had just one abnormality. Then we had those who had two abnormalities, standing at 17% for female and 29% for men. And this is where our definition begins, 2 or more abnormalities. The next graph is looking at the prevalence of kidney dysfunction by age. And what we show here is that among those who are 60 years and above, the prevalence of kidney dysfunction was actually much higher at 44.3, followed by the younger ones. And then we have the ones 50 to 59, and the p-value here was also quite significant for us. Then we show disaggregation of that previous slide by sex and age, and you see here that still among those who are 60 years and above, it's more in the men, where we had 57.6%, and among those 50 to 59 at around 41.9%. Then this one shows the prevalence of kidney dysfunction by duration of exposure, which is what we're trying to report, to test in our hypothesis. And still you see that with increasing duration of exposure, you actually have a higher prevalence of kidney dysfunction. And this, to me, has a near linear pattern, although the p-value was not statistically significant. Then this is giving us the prevalence now disaggregated by gender. And still you can see that among those who have been on treatment for so long, the prevalence of kidney dysfunction is higher. This is giving us an age and gender adjusted prevalence of kidney dysfunction. And so even after adjustment, you still see that with increasing duration of exposure, you have a higher prevalence of kidney dysfunction among the participants. Then we also did assess vitamin D, which is quite interesting. And here we found that 60% of the participants had insufficient levels of vitamin D, which is quite staggering. And I thought of analyzing that particular aspect further to give us this output to see how closer to deficiency or to normalcy the vitamin D insufficiency was, and this is how it played out, that about 8% were closer to deficiency, and only 34% were closer to normalcy among those who had vitamin D insufficiency. This is something to bring the heat map home, and here we try to distribute our 420 participants by the heat map criterion to see how this cohort played out as far as kidney dysfunction was concerned, and this is how it looked. So we had about 42 participants who had eGFR less than 60. And those ones are the ones who are currently being followed up for the 90-day test to be able to classify CKD. So for discussion, this is the first study to use a stratified-based approach based on duration to determine dysfunction of CKD. Our results show that the overall dysfunction is 27.6%, and particularly this is higher in those who are of advanced age and among men. The results also demonstrate a high vitamin D insufficiency rate, which is staggering in my opinion. And these results actually show an unmet need for supplementation amongst patients who are HIV positive. When we compared with other studies, the key study I compared with is Dr. Nyende's study, which had found, which was done here in our setting, which had found a prevalence of dysfunction of 2.52%, but our study demonstrates 27.6%. These results are also, however, consistent with those of Wantakisha et al., who reported decline in kidney dysfunction among his patients on TDF, although the dysfunction they reported was mild and the duration was shorter. We also show that our results are also consistent with Mwanjala et al., 2022, who reported a prevalence of 20.7 among patients on ART, although ART was not specifically TDF and the temporal aspect was shorter, about 24 months. So this study is also the first, to the best of our knowledge, to consider vitamin D among patients on ART and reveals an important finding that calls for action for us to do more research on that particular aspect, but also provide supplementation for people living with HIV. And I therefore, given the rate of kidney dysfunction, advocate for a number of things. One, availing a less toxic regimen for people living with HIV as soon as possible. Then timely and scheduled routine RFT testing to be incorporated into HIV chronic care for all patients on ART. And such testing, and the frequency of such testing should be tailored to the duration of exposure, and then upgrading of such monitoring to a quarterly reportable indicator of all HIV programs to aid early identification of individuals needing intervention, and then yearly screening for vitamin D, and availing vitamin D supplementation for patients. I hope together we can strive to preserve the kidneys of people living with HIV for a better life. Thank you very much.
Thank you, Cuthbert. Dr. Nakavugo, where is she? Nakavugo is going to show us something about mortality outcomes among patients on hemodialysis in Zambia Hospital. How many slides do you have? There should be 3. Huh? 10. You can't present a slide in 1 minute. It should be 3 slides. Okay. You present in 10 minutes. You are going to start now.
Thank you so much. My name is Dr. Nakatumba Irene. I thank my mentors, Dr. Ogavu and Dr. Atuhe, for assisting me with this study. I am a physician at Zambia Hospital, currently stationed in the nephrology and dialysis unit of Zambia. So I'm going to look at the predictors of hospital survival among patients that are initiated on hemodialysis. We have all known that survival among these patients is low, but the questions that patients usually ask, doctor, will I survive? And then at time you go back, you're like, why are these people dying? Why are these people dying? And this is the question that we are going to answer this afternoon in a few minutes. So the prevalence of kidney disease is increasing globally, even in our countries. And among all the so many things that are supposed to reduce death, hemodialysis is one of those that have been introduced, with over 7 million people requiring dialysis worldwide. Much as this is a life-saving technique, it comes with so many things. It is expensive, it has limited access, especially in our countries, and survival rates remain low. I should say that survival rates have been studied even in our countries and ranges between 47.5 that is by Kwizera in Uganda in 2016, who studied survival or mortality of patients that had been scheduled for dialysis among patients that had KI in ICU to 65.9% in Rwanda. We also know that survival is actually higher in high-income countries, ranging from 85 to 90% in different communities. However, we also note that predictors of survival in high-income countries have been studied, but little is known about this in our countries. It is very hard to apply the same predictors that are known in other countries to our settings where we have few nephrologists, we have few dialysis centers, and so that informed the reason as to why we went ahead and studied this. So our objectives were majorly three: to describe the indications of hemodialysis, to determine the hospital survival of patients interested in hemodialysis. This was actually it was basically just survival, how patients did in hospital. And lastly, to describe the predictors of hospital survival among patients. I will not talk so much about this, but we looked at different things. This was our conceptual framework: the demographics, the clinical population, the comorbidities or risk factors for kidney disease. And then we also looked at the indications of hemodialysis, the biochemical and treatment factors. Yeah. So this was a retrospective cohort study. It was an observation study. We analyzed medical records of all adult patients who had started hemodialysis at Nsambya Hospital between 2015 and 2022 December. We included all patients where they had AKI, CKD, because of numbers. We also excluded patients that had had renal transplant, patients that had missing records, and patients that were referred out of Nsambya Hospital before the time of discharge, due to different reasons. Sometimes patients come, and before you can decide on a discharge, they want to go out because of maybe financial constraints or other reasons. So from the patient files, we collected demographic, clinical, and laboratory and treatment details. And we collected this from the time the patient started dialysis, from the records. This is a retrospective study. From the records, from the time the patient starts dialysis to the time they're discharged out of hospital. So some of them would spend 3 days, others 5, others 20. The longest period was 3 months, that is 90 days. And we defined hospital survival as being alive by the time the patient was leaving hospital. So we analyzed this using a survival analysis methods, and Cox regression was used to estimate the in-hospital survival. And hazard ratios were also used. So out of the 453 patients that had started hemodialysis, who were screened, we excluded 281 for different reasons. And finally, we had 172 participants that were recruited. Chats that were involved in the study. And by the end of the study, we had 70 people that died before discharge. And I will I'll give you the results in details. So because of time, Dr. Sekasamvu, I'm going to give you the results alongside with a discussion. So 59.3 patients had survived by the time they're discharged out of hospital. That is not surprising. It's a low survival. It is within the rates that I've given initially during my introduction, between 40 to 69. It is higher than what Dr. Kwizera had done, of 47 in IHK, but also lower than the one in Rwanda. Our average hospital stay was 10 days, and it is not surprising that most of our patients were male. From what Dr. Kansime has been giving us, most of actually the patients that we have in the dialysis units are male, 61%. Maybe because men can afford the dialysis, they have the money. I don't know, someone can go ahead and study why most of our patients are male. And out of the 70 deaths that we had, 70.5% of this died within the first 14 days. So out of the 70 deaths, we had 53. Over 50% of them die within the first 14 days. What does this mean? That if a patient is started on hemodialysis, as the caretakers, as the clinicians, as the nurses, we need to be more careful during these first 14 days because they're very critical, and this is the time that the patients die in. So, yeah. The second indication was indications of hemodialysis. The biggest indication was uremia at 88%, and the least was intoxication. I didn't put so many tables, but we had 2 patients out of the 172 with normal kidney function. And all this was because of DKA. Patients come in with DKA and then they are dialyzed with normal kidney function because of refractory acidosis. But significant to note, acidosis was a negative predictor of survival. Out of the 109 patients, 51 of them actually survived only compared to the others. So we need to be careful and we need to know or learn about how to manage acidosis. However, in a study that was done, other studies, most of the studies that have been done, hyperkalemia is one of the negative predictor of survival. So patients that have hyperkalemia die more. However, in our setting, hyperkalemia was not any significant to death or survival in our setting. So maybe probably the people that are taking care of patients in Zambia have learned about the medical management of hyperkalemia. At bivariant analysis, the positive predictors of survival included being male, age less than 60 years, and prior knowledge of kidney disease, or being under care of a nephrologist. Most of these patients that most of the patients that were initiated on hemodialysis in Zambia didn't have any prior knowledge of their kidney disease or function. And when you look at this, only 56 of them out of the 172 were aware of their kidney function, and actually these survived more than those that were not aware. Still, the negative predictors of survival included being unconscious, being on mechanical ventilation, and vasopressor use. Basically, patients that were critically ill were at a higher risk of dying by the end of, during the time they were admitted. The other variables were not significant at this time. I will not go much into that. So the strength, I will still not go into the detail because my time is done. But I'll look at the conclusion. In conclusion, there is low in-hospital survival rates among our patients. And as we have seen young patients being male, being admitted on the wards instead of ICU, and those people that have prior knowledge of kidney disease do well after being initiated on dialysis. However, patients that are critically ill are less likely to survive. So this information is very important for us as we initiate our patients on dialysis, as we counsel them, as we answer the questions of, doctor, will I survive or not survive? Will I make it or not make it? So the recommendation is to ask you, the clinicians and all the teams that take care of patients that are initiated on hemodialysis, to equip ourselves with skills in order to know and plan to critically manage our patients. Our hospitals equipped with equipment for us to manage critically ill patients. Our supplies of ABGs, our supplies of renal function tests function all the time. And since most of the patients that knew their kidney function prior to starting dialysis actually survived, it is very important for us to screen and actually refer these patients that have kidney disease to care of kidney disease. Thank you so much. May God bless.
You did well, you kept the time. Now, we are going to have, I think, the most important presentation of today, and that's why I was trying to save time. So, Dr. Kansime, I'm not going to limit your time, but remember that we are hungry and we also have the AGM.
Should be fasting. It's Friday.
Fasting? Need Daniel. Okay. So, Dr. Kansime, I'm not introducing her, but she's going to talk about a very important subject as far as development of nephrology as well as management of kidney disease in the country is concerned.
Thank you very much, boss. I have kept advocating for equity. It is coming. So it is hard to speak, I know, when I am standing between people and their lunch. So I will do my best. So we are going to talk about establishing the Uganda Kidney Disease Registry. I have no disclosures, and I am presenting this on behalf of a very big team of Uganda Kidney Foundation. These are the champions. So, a disease registry is a systematic collection of data about individuals with a specific diagnosis, condition, or procedure, and in this case, kidney disease. So very many countries developed and developing rely on registries and consortia to generate high-quality data for planning and decision-making and making policies. So registries collect detailed information on specific diseases, in this case, kidney disease, populations, treatment outcomes, and this data helps researchers, healthcare providers, as well as policymakers to make informed decisions about prevention and treatment strategies, the things that we are advocating for. So, the African Renal Registry. It was established in 2015, 10 years ago, and it is open to all African countries. In the meeting in which it was established, adopted, Dr. Seka, infrastructure be adopted by the African Renal Association, the AFRANI, so that they can help the rest of the African countries. So you can imagine it's as if every year just one country joins. But what happens actually, countries join, put in data for 2 years, 3 years, and fall off. So, the call to action is that there is a need for integrated strategies and improved access to care, and data from registries would do this. So, we know kidney disease in Uganda. We have made a great stride, as we have said throughout this, over the past 10 years. 2 years ago, the paper that we published with Dr. Kalesula, we had like half the centers that we have now. Right now, we actually have 29 dialysis centers, 6 public, 23 private. It is still far from adequate. We still nephrologists. We have 70 trained dialysis nurses. But while we are trying to smile, we remember that the dialysis centers are in only 6 of the 130-something districts in Uganda. And remember that each district, meant to serve about 400 people, now serves up to 1.5 million or even more. And these 29 centers, 75% of them are within a 10-kilometer radius from. So you can imagine what people in Kabong, wherever, are going through. To date, we have about 600 patients on chronic dialysis, but this we estimate is only 15% of those who actually need it. And we know the reasons very well. We've already seen the access, the availability, the cost, and of course, lack of insurance, so the financial challenges. And these challenges are just affecting the access to treatment, but they are affecting access to data. Data is not being generated. And data challenges, as we've seen, affect policy and planning because the data is fragmented, and hence the birth of the Uganda Kidney Disease Registry. So the scope is to include adults and children. The goal is to generate information on prevalence, incidence, causes, treatment, all those things we've talked about. We thought that we would implement this in phases. So the bigger picture is kidney disease, the whole umbrella. But we thought we already have people that are already organized and coming to us in the hospital, and these are patients on dialysis. They are accessible, and so we thought that would be our phase 1. And then in future, we would think about including people not yet on dialysis, or even those that have transplanted. So this is to be implemented in partnership. We talked about stakeholders yesterday, so Ministry of Health, but also in collaboration with the African Renal Registry. So all patients initiated on dialysis so that we get to know eventually who is AKI, who is CKD, all sites, and the personnel that would have a nephrologist leading this, then would have an administrator, and then data entry would be by nurses selected from each site. And when we look at data, these are a few questions that have come up, so I am preempting. As we said, we actually use it to get to tell who is South African, who gets access to dialysis, and all that. Here, we still have concerns of, I am Dr. Grace, someone will know that I have CKD and I am on dialysis. So we have to work around that stigma. Sometimes we don't know that it exists. But then we are asking, where are you doing your dialysis? When did you start? What is your date? And which modality are you using? When did you start this? Who is your doctor? And where do you come from? We thought of using, is it south, west, and north? And what is your primary diagnosis if known? How was it made? Is it confirmed by biopsy or not? What are the comorbidities, the usual ones that we know? And that's it. That's all. And we get you into the registry. And then, every year, we have an assessment form, sort of to say, are you still alive? Do you have a residency and dialysis center and a modality? If you started from PD, are you still on PD, or have you moved? Have you changed doctors? And also that's it. That's all the information. And the reason why these forms and this information that we are collecting is just the minimum, because we do not want to tire the people that are collecting the information. Everyone should feel like this is something that I can sit and in 1 minute, I have filled all this information. And as you can see, this is information that we collect daily when we are initiating patients on dialysis. Then there is a transplant procedure form in case one transplant. And if someone stopped dialysis, transferred for some reason, so the stopped, those would be the AKIs, or if they stopped because of money, so would have a reason, or if they died, and that's it. And to accept as a national society, you sign a memorandum of understanding, and this is just a copy of that with the African Renal Registry. Okay, so that means that if we collected this data, Uganda Kidney Foundation would own the data. Like I told you, the leadership would have, so locally, each center would have access to center data, and not everyone, if we have 15 nurses in Chirudu, not everyone will access data on the registry. Only the selected people who will have passwords, and they will be the ones to access the data. And then the regional one, the access will be for the UKF. And dissemination of results, just like I said, of findings, it would be annual reports, academic presentations, media releases, and whenever possible, journal publications. Usually this is only aggregated data. So even in Uganda, you would say, okay, we had like so many private dialysis centers and so many public, and this is what we have. So we wouldn't want to say, okay, this is Mulago versus Nakasero. No, aggregated data. And then there are guidelines. If you were to author, you would follow the usual guidelines really for publications. So the ethical and legal considerations. Because at some point this is data that is going to be published, you have to get ethical clearance. And so we're in the process of getting ethical approval from REC at Mbarara University. We have actually received first comments, which I have to respond to. We requested for a consent of waiver. Unfortunately, in the comments that we've received that we are yet to respond to, they're asking us to get consent from each and every patient. So what I realized, and this is the reason for the advocacy, is that when you submit to REC, the people that are reviewing whatever you've submitted, they have this idea of research, research, and research. In Uganda, we do not have very many registries. I know we have the rheumatic disease registry. We have a cancer registry that was for a long time ago. So even for people who are doing the approvals, this may be new. So we have to educate people as to why we are doing this. And then funding, that's for now, that would be the responsibility of Uganda Kidney Foundation to ensure that the registry is established and maintained. Underline maintained. I wouldn't want us 2 years down the road to come and there is no updates from the registry because we peeped in and pulled out because we couldn't maintain. So it has taken 10 years and it will take a few more months maybe in planning to make sure that once it is established, we really maintain it. And of course, to lobby from partners and government as we always do. So like I said, we've applied for REC, we are responding to initial comments. We've identified and trained key persons at most centers, most, not all of them. There are still a bit of reluctancy, particularly with the public unit, with the private units, and that's okay and expected. We expect the nephrologists that are in those units to help, but we also thought that irrespective of whatever is happening, we start and others will join us. We hope that we shall sign a memorandum of understanding with Ministry of Health and eventually with Afrani after getting the ethical approval. We are really hoping to partner with Ministry of Health because the wish would be that the Ministry of Health that actually co-owns this, especially in the light of the new units that are starting, that tomorrow whoever will be in charge of the CHAZE will not have to go and beg a unit that is starting to join the registry. That it will actually be a prerequisite that once you open a unit, you join the registry. So that's the hope. Thank you.
We are going to ask questions. We are going to ask one question for each of the presenters, and then we are going to ask 4 questions to Dr. Kansim. Now I'm waiting for a show of hands.
Thank you. If you want to ask Kansim, don't ask another person. No, I'm going to ask Dr. Cuthbert a question. 2 questions in one. First of all, why did you categorize the time? Why didn't you just leave it as continuous? And did you get what you wanted by doing that? Because the associations could have been stronger with a continuous variable or easier to demonstrate. The second thing is this function, are they linked to mortality or
progression to dialysis, or is there a reason why we should be concerned about this dysfunction, or is it just an abnormality that people can live with?
Another hand. That's one question to Cuthbert. Huh? Variables. Come.
This is for Professor Kalesubula. We're doing a lot of rethinking about medical schools and how we train our students and what outcomes we want. So for your presentation, I wanted to know what is the key thing that you'd want a fifth-year medical student to know about this cardiometabolic syndrome? How would you want a fifth year to be able to articulate it?
Mm-hmm. So another? Uli rudda wa? Otambula kono jeno. Otherwise you will catch DVT, my friend.
Thank you. Mine is to Professor Kalesubula. Thank you for the presentation.
Oyeba mumaze. Buze chirala. Nagambi one question.
Really important.
Go ahead.
If you have a patient who has diabetes, kidney disease, what would be the rationale of putting the patient on the 4 drugs to protect their kidneys? Yeah.
Okay. Another question? Muli kumpi ku Kansime teyayogedde temwategedde bye yagambye.
To Dr. Kansime, we usually start dialysis, initiate them, and then refer them to either Bagasha or Daniel. I'm wondering whether we would be expected to fill the registry or the people where we've referred them to.
Echirala. Somebody else? Tujira tutandika, Professor. Where's Cuthbert?
Thank you very much for the question. How to express the cardiovascular kidney metabolic syndrome to a 5th year. 5th years are advanced. They even now spend, I think, 2 years before they practice because they have no internship space, thanks to our government. Anyway, the key here is that, as I try to show the cardiometabolic syndrome, is that we have common pathways of causing injury. So in the past, we used to talk about kidney, then we went out and talked about the cardiorenal syndromes. The cardiorenal syndromes were basically, there are 5, they were looking at either the heart causing problem to the kidney, or the kidney causing problem to the heart, or a systemic disease coming to cause problems to both organs. But we realized that actually the common pathway to this metabolic disorder comes from abnormalities of fat. And all the cells you see, the GLP-1, all these things we are talking about, they all begin with lipid metabolism. And in the end, they share the pathophysiology. And so if we can address these diseases together, having an intervention for each of the spectrums of the disease, then we can actually be able to reduce mortality in these individuals. But science doesn't work on pathophysiology only, it works on evidence. And so all the slides Brian and I went through were to show what drugs can help to actually stop the disease from progressing or even killing people. That also answers the person who is asking about the rationale of why we would use these 4 drugs. We use these 4 drugs because they have pathophysiological basis, but more importantly, they have incremental benefit on reducing mortality. For the longest time, as I said earlier, once you got kidney disease, you all know everyone would say, even now, people say, olwadde ensigo ofudde, wandiika eddaame. You just write your will. But for the first time now we have these molecules that can act in different ways. Please remember, those 4 molecules are not for anyone with kidney disease. They are for someone who has diabetes and chronic kidney disease. So once you diagnose diabetes and chronic kidney disease, then this individual should be on those 4 drugs because of the benefits.
Yes, Dr. Chigundu, thank you for your questions. Why did we categorize? In my introduction, I showed you a slide which, from work by Shaz et al., which had shown us that for every year of exposure to TDF, there is an increased risk of kidney damage. That what the prevalence of such dysfunction is and such damage is stratified by the different exposure durations our patients have, because patients have been on TDF for a very long time. I think earliest here is from around 2010 to now. Those are so many years of exposure, but we also have those ones who have been on it for less than, some of them for 1 day, for 2 days, for 3 days, for 1 year. So we needed to understand what the prevalence of dysfunction is in the different categories of exposure that we have. And also, you know that our program has had so many shifts. We've shifted from D40 to AZT, now to TDF. And those factors are also considered in this study to see how they influence the kidney dysfunction in these patients. And then as far as dysfunction is concerned in relation to progression of kidney disease, I think it's one that if TDF is a tubular dysfunction, but if you get overt tubular dysfunction, it can actually spill over to glomerular dysfunction as well, to glomerular damage. And we have seen patients who progress to end-stage renal disease needing dialysis simply because they've been on a regimen for so long that damage their kidneys without being recognized. And the beauty is that when you pick this damage early and you change the patient's regimen, there are actually reversals. You can see an improvement in the kidney function of the patient, and this has happened. I don't know whether that answered you properly.
Thank you, Dr. Nakanda, for your question. So, like I said, the South African Renal Registry, from which we are really copying and adapting, uses the national ID, so the NIN. So that is their unique number. In the event that that is not possible here, we shall assign a patient a unique number. So they do not get that number twice or thrice, it is once. And so once you transfer, and transfer means you've transferred, you've changed the modality, you've changed the doctor, you have changed the sector from public to private or vice versa, or there will be a transfer form with a reason as to what is being transferred. So to answer your question, if you start a patient, you enroll them into the registry. Once they transfer to Dr. Chigundu or Dr. Bagasha, they are transferring from one center to another, they are transferring from one doctor to another, so we shall fill a transfer form for them. So on every form that we are filling, we are maintaining that unique number. That's why we communicate. And the transfer is a transfer, not a visit. So when people are visiting from Kampala, they're visiting Barara and they call Dr. Rose in advance and they're going to be around for 1 month, that's not a transfer. So the transfer is a transfer. Yes.
I'm not going to allow any further questions. We have run out of time. Personally, I have a lot of comments to say about this, but cheers. You come and perform a very small function before I do some final thing. Hey, there was a draw here. There was a question, a draw. I think somebody is going to get an electric car or something like this. So we want to do the draw. Then UKF is going to talk to you for about 5 minutes. And then we shall go for lunch. And you know UKF has to talk to you. Huh? So UKF, you come and talk while the draw people come. Here, there.
Okay, I see it is sealed. So let's see. The correct answer was C. We go again. Okay. This is C, but this is me. Oh, since, let's see another one. Okay. I hope people don't serve rigged. This is another C, and this is Dr. KabiraCountryClubKampala, but I think it's unfair. Huh? We first check. For the second winner, we are going to first.
So for those who didn't get the question, maybe you can visit the Ajanta stall. We can still give supplementary gifts for those who guessed, but obviously now you know the whole answer. But Dr. KabiraCountryClubKampala guessed he's the lucky winner of the lucky draw, and he gets a present from Ajanta. Thank you so much.
Let's see. Me, I'm seeing the names even. Okay. We have another C, Rose Muhindo. I didn't rig. Okay. Hey. Okay. Come together. This side. Thank you. Dr. Sekasam, who is the UKF representative?
Let us now talk UKF. Are you ready? Yeah. Okay.
Thank you. I will take just a few minutes to talk about UKF, Uganda Kidney Foundation. For those who don't know me, I'm Sally Nicholas. I'm a dialysis nurse. I work with Chirudo National Referral Hospital, and I'm the Secretary General of Uganda Kidney Foundation. I'm also the training coordinator of dialysis nursing program under Uganda Kidney Foundation. So Uganda Kidney Foundation is a non-government organization, non-profit making, health related, that was founded in 2011 by a team of medical doctors, nurses, working with kidney disease patients to explore ways and means of reducing morbidity and mortality due to kidney disease in Uganda. This organization was founded by Professor Robert KabiraCountryClubKampala, Dr. Joseph Runyera, and Dr. Peace Bagasha, Dr. Ngabire Pros Merab, with Dr. Sekasambu Emmanuel as the patron. This organization drives its innovation through various strategic partnerships and investments in different clinical research so that they can be able to improve the patient outcomes and fight tirelessly for legislations and health policy. In 2019, UKF was able to lobby for dialysis money that was given to Chirudu, We are so grateful to the UKF administration by then that now patients can get dialysis at a very cheap cost. The current executive of UKF, as displayed, we have Dr. Ogavu Jagenda Joseph, the president, Dr. Muhindo Rose, the vice president, Mr. Sally Nicholas, the secretary general, Miss Olive, the treasurer, Dr. Kansime Grace, the head of projects, Dr. Daniel Chigundu, the training coordinator, Dr. Peace Bagasha, the research coordinator, Mr. Mukasa Joseph, the communication and publicity officer, and Miss Kabuye Amina, welfare officer. What's the vision of UKF? The vision of Uganda Kidney Foundation is to enhance the lives of everyone with or who is at risk or who is affected by kidney disease. From studies that were done locally by Prof, we have seen that Prof usually says that in every 10 people, at least one of you has a problem with your kidneys and you don't know. And it is good that this year's theme is that your kidney is okay. So we encourage each one of us to screen and know the health of their kidneys. The mission of Uganda Kidney Foundation, we are committed to prevention and managing kidney disease through awareness, education, and research. We do a lot of awareness in media, we do a lot of training, and we do a lot of research. Because this is in line with our mission. We have two broad objectives. The first one is health promotion, whereby we need to enable people to increase their control over kidney disease in their everyday life. We don't want people to suffer from kidney disease. We want them to remain healthy. And our overall aim is to see that the population of Uganda is educated, is aware, is empowered, and is equipped with clear, accurate, and credible information about the quality of kidney health. So, members who are here in this conference, we encourage you to join us in this drive so that we can advocate for quality kidney health. Thank you so much. Before I conclude, one last presentation that I want to share with you. I told you I'm a nurse by training, by foundation. So as nurses who are involved in renal care, we came up with an association called the Uganda Renal Nurses Association. This association is a professional body that we registered in 2024, and membership is for all nurses who practice nephrology. We have an interim body, and our patron is Mr. Jambo Joshua. Sally Nicholas, I'm the president. Tibengana Ellison is the deputy president. Waiswata Deo is the secretary general. Nick James is the vice secretary. And Masereka Thompson is the treasurer. What is our vision as Uganda Renal Nurses Association? We want to be a worldwide professional body that is charged with enhancing the provision of quality renal nursing services. It is a big vision, and we want your support to be able to fulfill this vision. We have a mission, and our mission is to participate in the provision of preventive, promotive, curative, innovative, and research services in renal care. We have very many objectives, but just a few, to set forth and update standards of renal nursing in Uganda. Why do we say setting forth? Because we don't have these standards here in the country. So as an association, we want to set those standards, and we update them so that we don't only copy from those that are out, but we bring them to our local context. We want to lobby for support from the relevant authorities so that we are able to formulate policies that matter, especially to do with renal nursing. Promote and conduct research in renal nursing, and to be able to provide mechanisms and stimuli to promote individual professional growth. And lastly, is to provide continuous medical education to all members and colleagues in the profession. So for the nurses who are involved in renal care, you are highly encouraged to come and join us, because the Baganda have a saying that agali awamu gegalume nyama. Thank you for listening. Before I conclude,
how
do we join Uganda Kidney Foundation? So, joining Uganda Kidney Foundation, you register with our secretariat. We have an admin. Right now is at the registration table at a fee. Membership to Uganda Kidney Foundation is 50,000, and you subscribe every year 20,000 shillings. Only. That is very little money, and it is very affordable. The benefits of being a member of Uganda Kidney Foundation. The first benefit, like we are here, we have a lot of social networking. You see, when you rub shoulders with a consultant, when you have a patient, a relative, a friend, a consultant is just a phone call away, even if it is late in the night. We have various consultants we work with. So in Uganda Kidney Foundation, because it is an association of various members where we come together, everybody who is interested in advancing kidney health is free to join the foundation. Another benefit, when you're a member, you can have training opportunities. Like yesterday, we had a presentation from Dr. Ruiz. Because he's a member, he easily got a scholarship to go and train to do his fellowship in Canada. So if you're not a member, you may not get these chances. Research. Many of us are doing research, and many of us want mentors, want supervisors. And in Uganda Kidney Foundation, we have these people. So when you join Uganda Kidney Foundation, it is very easy to get a mentor, to mentor you in research. It's very easy to get a supervisor. Another benefit of being a member of Kidney Foundation, continuous medical education. Last year we had monthly webinars to help improve and update us with knowledge about kidney disease and management. When you're a member, every month we normally have these webinars where we come together and people who have done research, who have research papers, present updates. So as a member, you always open to these new updates in time. Thank you so much.
Thank you very much. Dr. Jagenda, you realize we are going to modify our program a little bit. We are late, and since the bigger majority of us are fasting, the ones who are not fasting will somehow bear with us. When you look at your program, we have a closure and awarding ceremony between 15:30 and 16. And we have a AGM. The AGM will probably be the highlights of this. So what we've decided is that we do the awarding ceremony now, and we go for the AGM. So Dr. Jagenda, please take over the award ceremony. Then we shall do the lunch.
Thank you very much. We realize that if we get into the AGM, we may not do some of these things. So as I talk now, I will ask all the farmers to send their representatives down here so that we can actually see who are the force behind us being able to prepare this. So please kindly send us a representative, or you could carry your team and anything you want to show us when you come down here. So I want to thank all of you for sparing time to come and join us in this activity. It means a lot for us, and it must be fulfilling for people like Prof. Kalyesubula, who sat wherever they sat. Was it a mango tree or wherever? Maybe it was some bench at which guest house, I do not remember where. But to see that what began as 6th floor Mulago, yes, and here we are. So thank you very much for loving nephrology, and we wish that nephrology becomes brighter. We wish that it will be easier for you much more than it was for Prof. Kalyes and certainly ourselves. And we also hope that you've learned a lot. We are looking forward to a day when it will be your turn to present here and be here and assist Kenneth, whom I must thank now before I forget. Thank you very much for really helping us. We really appreciate it. And we wish you the best in your nephrology career. I hope you're still on course. Yeah, so I want to take this opportunity to, and this is in no specific order. Yes, AstraZeneca. AstraZeneca, this lady has journeyed with us for a very long time. Connie, thank you very much for the support. This is dapagliflozin, Forxiga. Yes, we can't forget Forxiga. So we thank you very much, AstraZeneca. I want to thank Eminent. Maybe they're coming. Microlabs. Yes, Microlabs, they have quite an army. We thank you for your support always. And I want to, anyone that has been carried beyond rivers and cities by Microlabs to come and be here, if you would kindly stand up. Yes. Yes, so thank you very much for helping us to bring these people here. It means a lot to the future of nephrology. Thank you very much. Troika. Yes, Troika. Should I say Zaika or Neurotroy? That's B12, eh? That's what B12. Yes, but, all right. Crown, yes. Supporting many of the private facilities with setting up dialysis. Marvin, thank you very much. We really appreciate you. Denk Pharma. Something used to happen in October. I don't know what happened. It's coming back soon. Eh? Those that have understood, they have a diuretic that is usually celebrated in October. So thank you very much, Denk. Novo Nordisk. Novo, yes. Austin, majestic as always. This single man and, no, as in, okay. Lift up your left hand. Okay, so I mean the other one. He single-handedly visits all of us and tells us about this molecule. That's what I meant. Yeah, yes. Centaur, metolazone, metose, and Renadil, and amlotrust, and what else? Oraxine. Yes, thank you very much. Crown Pharma, I mentioned, they have not come around. Oh yes, Crown, yeah. Yes, Oncofarm. Among those is my OG. I won't tell you whom. You can give me one of them. Thank you very much for HEMAX and for revolutionizing erythropoietin therapy. It means that someone in China Mukaka can actually be able to have a chance to have a good HB. So thank you very much. And for bringing down the cost of anticoagulation, which we know plagues many of our patients that have acute kidney injury. Wide spectrum. Yes, thank you for your wide range of molecules. And I know even beyond this, you support many learning events at many of these sites. Please continue. And Ajanta Pharma, and for choosing only C's, but I'm sure none of us complained. It went to the right hands. Thank you very much, Ajanta, and for your support in many other ways. Sun Pharma. All right. Yashoda Hospitals, they gave us quite a good injection, and they deserve a lot of thanks. There are many of us that have sharpened our nephrology thanks to them, taking us to centers of excellence in Hyderabad. There's only one person they haven't taken. I don't know what the president did to you, but that's okay. But we thank you. We know how much you supported the country in transplant. You made this dream come true. Thank you very much. So Eminent is here with the OSEMA. OSEMA and the Canopas and the and Fematos, yes, and Roxatat. I will tell you one thing. One of my trainers told me that when people use ferrox carboxymaltose, they actually become happier. So I don't know if there's evidence to that among the practitioners. Perhaps that's one of the things you should use to market. Yes, I think I want to think I've covered us very well. Anyone I've not mentioned, please? Pardon? Yes. Mega Life Sciences, our platinum sponsors. I want to challenge you. This guy is what they have done. You can also do. But surely it's very possible. Some of you are telling us that we came to you very late. Some of you want notifications as early as a year. And you have actually agreed that next week, because we are going to choose the organizing committee, next week they are going to draft letters and send them to all of you, so that we're actually going to scrap Silver. We are going to scrap Dr. Nange, Mbele Libubina Etere, Kwatakano. So we are starting from gold. We shall find another level, but no more silver. So we are sorry when you have come to you late. We want to come as early as possible. So next week, please check your mails. I just want to choose a mail address. Now, yes, but let me take the chance to welcome Mega, Mr. Varun. I think Aaron is not here. Mr. Vivek, Simon, and everyone else. We really, really appreciate. Thanks for being. One reason we always come here is if we say Kabira, we actually don't need to struggle to make sure the tables will be well arranged. Our eats will be enough, and so on. So we thank you very much and for the partnership that you have with this place, but more so for having the assurance of you being the platinum sponsors. And like we have notified, we shall raise the bar for platinum sponsors, and we are sure you'll match up. So I want us to actually stand up and thank all the sponsors. So thank you, Mega. Thank you, Troika. Thank you, Michael Labs. Thank you, Eminent. Thank you, Crown. Thanks, Denk Pharma. Thank you, Novo. Thank you, Cento, Crown, Oncofarm, Wide Spectrum, Magenta, Yashoda. We really, really appreciate. May God bless you, and we wish you the best health in your kidneys. Yes. All right, so I don't want to stand between us and lunch. Oh, yeah. So for this, we thank you for making us smile, so show us your best smiles. All right. Thank you very, very much.
Thank you very much, Dr. Jagenda, for that. Well, it's now time for lunch. We have the AGM. Time is not on our side. Today is a Friday with associated jam in town. So I would request us to really have a 30-minute lunch and come back here for the AGM. Because without the AGM, we can't proceed. So let us, it's now 2:30, 3 o'clock, the AGM is starting. Okay, thank you very much.
nation that is over 35 with international manufacturers has a very good advantage of giving us a short lead time into bringing the special imports and the drugs that we're supposed to bring for the patients. And it also helps us to source those rare drugs. I want to give a special thanks to the team that did kidney transplants. We want to also say thank you because we were able to supply some of the rare drugs that were needed during that time. Patients of adult surgery patients in autologous pre-donation program, you can use HEMAX during that time. So HEMAX in the treatment of symptomatic anemia in adult chronic renal failure patients, the recommended dosing, the recommended HB is 10 to 12 grams per deciliter. So the dosing standards for HEMAX for patients who have a symptomatic anemia with chronic renal failure, in adult patients, we're looking at a correction phase. Under correction phase, we're going to use 50 international unit per kilogram body weight 3 times per week. In this case, I put, if your patient is, for example, 70 kgs, And you're going to multiply 70 by 50. I think you should get approximately that 3,500 and something. So in this case, you may have to go for a 4,000 international unit where you can give it 3 times a week. And then in the maintenance dose, you can give a total of 75 international unit per kilogram body weight on the minimum side, and then up to 300 international unit per kilogram body weight on the higher side. Adult patients with renal insufficiency, not yet undergoing dialysis, in the pre-dialysis setting, we also use 50 milligrams as a correction phase 3 times a week. And then maintenance phase, we can also do 50 up to a maximum of 150 kilograms per body weight, 3 times a week. We can also do a once a week dose where you can do 240 milligrams per kilogram body weight up to a maximum of 480 international unit per kilogram body weight. Adult patient under peritoneal dialysis, this one goes more to Dr. Oriba because he's the one doing this a lot. So the starting dose is 50 international units per kilogram body weight twice a week. And then maintenance, we give 25 international units to 50 international units. This is where you find 2,000 international units being used, and then 4,000 being used mostly twice a week for patients in peritoneal dialysis. And various methods of administration I mentioned earlier, you can use IV or subcutaneous routes. If you're using the intravenous routes, you can administer at least 1 to 5 minutes, depending on the total dose that you have. Subcutaneous routes, remember, HEMAX comes in 2 meals, so we are saying a maximum volume of 1 meal per site for injection in case you're going to use the sub-Q. So a brief recap on HEMAX. Take home. You don't need refrigeration for HEMAX. If you have a patient, you don't need refrigeration. So you can just put it on the room temperature, put it in the bus, let them receive their erythropoietin wherever they are. And it comes in multiple doses. That is 2,000, 4,000, 10,000, and 20,000 IU. The other thing you need to note is we also make it very affordable for the patients because our mission is to make sure that all patients receive their drugs affordably. That is the end of my presentation. My name is Susan Angura, and those are my number. Any questions? You're welcome. No question? Okay.
Members who are still outside, please come in. We are beginning our AGM. All members of UKF who are still out, please come in. Those who have not yet paid their subscription, please see our admin. The new members who want to pay their membership, see the admin. Good afternoon, members. Once again, I want to welcome you. Can I call this meeting to order? Dr. Narule's table. What is projected on our screen is our proposed agenda for our AGM. Item number 1 is opening prayer. Item number 2 is confirmation of the quorum. Item number 3 is adoption of the agenda. Item number 4 is a speech from our patron. Item number 5 is a report from the treasurer. Item number 6 is a report from the president. Item number 7 are reactions to the different reports. I would like to request Dr. Rose to give us an opening prayer.
Thank you very much, Sally. Let's humble ourselves and pray. Dear Lord, our loving Father, we want to thank you. We thank you for everything that you have done for us. Thank you for the 2 days that we have had together as a team. Thank you for everything that we've been able to learn. We want to place this AGM into your hands. We ask that you will be in our midst. And we ask that you will be the center of our discussions and help us to come with a way forward. We thank you and we praise you. In your mighty name we have prayed.
Thank you so much, Dr. Rose, for that prayer. At this juncture, do we have quorum to start our meeting? We are over 50 members in the foundation. And according to the attendance, I think we have quorum to start. So as projected on our screen, we have the agenda. Do members agree with the agenda? Can someone raise the motion to adopt the agenda or to amend the agenda?
I move we adopt the agenda. I, David Martin.
Dr. David Martin raises to adopt the agenda as it is. Anybody to second the motion?
I, Rosemond, I second it. Do I have to add?
Thank you so much. The agenda we have adopted the agenda as it is, and I'd like us to move to the first item on the agenda and receive communication from our patron. Let me welcome Dr. Seka Samvu, the patron of the foundation, to give us his speech.
Can you hear me now? Double barrel, can you?
Mumpulira, can you hear me? Hello? Hello?
Hello, hello, better? And this one? First of all, I would like to appreciate all of you for your time, for your efforts and input into the service of renal care. I know it is very difficult to manage the different aspects of renal care because I've been there. So today I have decided to give this preamble speech from the bottom of my heart. I'm not presenting any slides or using audiovisual equipment in this presentation. In this room, who is 50 years or older? Anybody? Can see me? Kuthbat you are, eh? Anybody 55 years or older? 45 years or older? 40 years or older? 35 years? So actually the population distribution in this room is a reflection of the national population distribution. In Uganda, when you are 60 years of age, I think you are elderly, because the life expectancy is about 60 to 65 years of age. Some time ago, when we chose medicine as a calling, we went to train in medicine, and by then the training was mostly clinical, because we had very few diagnostic tools at our disposal. And your ability to make it or fail while trying to qualify as a doctor depended a lot on your clinical acumen and ability to translate theoretical knowledge into the clinical aspects of care. And as time evolved, we have now developed the diagnostic tools that you have access to that we didn't have. Likewise, in training as doctors, at the time there was no training of specialists and there were no specialties in medicine. The aim was to train an all-round doctor who could do surgery, internal medicine, pediatrics, ophthalmology, psychiatry, as well as other areas of medicine. And as we grew into medical service and training, we started subspecializing to become the different subspecialties as you know them today. At the time, we didn't have nephrology, neither did we have cardiology, as you see them today. The only subspecialty probably that existed was pathology. As we started training in the subspecialty and getting ourselves interested in the different areas of medicine, we got turned off by the trauma that we experienced while practicing in the different units. And some of the units that were very traumatic included the oncology, or what you call Cancer Institute. The mortality rate was very high, and the patients were very sick, and there was nothing to do for them. And eventually, as we developed specialized units, the other turn-off was the nephrology unit. And the reasons why it was a turn-off, because the patients were quite sick, the mortality was very high, and there was hardly anything that we could do for them. The people who were giving service in nephrology were working long hours, and nephrology was associated with healthcare fatigue and burnout syndrome. And on top of that, when you looked at healthcare funding, the funding at the time was mainly going into infectious disease, and more specifically, HIV. So if you worked in nephrology, you were sure to face all those things that I have talked about. But most of all, you were sure to have no money in your pockets. And that was a big turn-off. By the time we were training in nephrology, we had one nephrologist called Dr. Chigonya Edward. I don't know how many of you met him or how many of you were taught by him. But I remember Cuthbert, you saw Chigonya, yes. Because we taught you with Chigonya. So Chigonya was a nephrologist who had trained in the UK and worked in the 70s, and was the only doctor trying to establish the specialty of nephrology. Personally, I noticed a gap there, and my mission then, personal mission, was to actually make nephrology recognizable and attractive. And I knew once this is done, then we can establish the specialty of nephrology, and other building blocks will fall in place. To cut the long story short, I trained as a nephrologist. I left all my other work which I was doing in medicine, and I concentrated on nephrology. And by the time I finished my training, Dr. Chigonya was more or less retired. He was on his way out. And I plunged into this deep pool of nephro practice. And surely it was very difficult to figure out how to run this service. Nephro practice, as we know it, has got many different aspects to it, all of which have been highlighted in the different presentations we've had. The one and the biggest part of all is preventive nephrology, preventing people from getting into AKI, and if they go into AKI, to prevent them from going into CKD. And if they go into CKD, to prevent them from climbing the deterioration ladder up to the ESRD. And that is very difficult to do as a lone person. The other aspect was to take care of these already existing patients who had issues with their kidneys, who included hypertensive patients whom we were seeing in the hypertension clinic, included renal patients, included onco patients, and many other patients. So at the time, the decision was to establish some kind of visible renal care. First, entry point, establish a renal ward. 2, establish a renal clinic. And 3, identify renal care as a specific area of management in medicine. To me, developing a service as a lone person would be very difficult because you have to prevent, you have to do patient care, you have to do research, you have to document. Dr. Kansime was talking about a renal registry here. You have to update your knowledge, you have to attend CMEs, congresses, and that is a huge burden on the one person. So I thought the best thing to do if you want to develop any level of renal service is to actually develop the human resource first. Develop the nephro nurses, develop the dialysis technicians, develop the nephrologists, and develop the pathologists to incline towards nephro, and also develop specialized services of care in renal services like dialysis, transplant, kidney biopsy, and so on, as well as chemistry. At the time, it was very difficult to get a serum creatinine done on anyone. And I think people didn't even know what a creatinine was. And that is where it all began from. Right now, I can say I'm happy because in this room, we are seated very many of us. And even without the presence of me or other senior nephro people, nephro training, nephro care can go on in this country. I must say I'm very happy because now the government is aware about nephro care. Hospitals are aware about nephro care. And the dialysis has become a household word. That is why, as Dr. Rose and Kansime were intimating, nowadays everybody wants to open a dialysis unit. All the small clinics or hospitals and everyone wants to be identified by a dialysis unit. Is that correct or not? So whether they have the human resource in place or not, they want to establish a dialysis unit. But the most important thing is the human resource. So that's why you had some people say that I am the one who mentored them, I taught them. My idea was to attract people into nephrology so that we have a critical mass. So right now I can happily say that there are people who are practicing nephro in Gulu, in Imbarara, in Wachiso, Kampala, Jinja, and all over the place. And so my granddaughter, Dr. Kansime, your work of establishing a renal registry has, I think, been made easier by you having human resource in place and the people with whom you can talk nephro language and they understand your form of acute kidney care, chronic kidney disease, dialysis, no dialysis, whatever. So it will be easier. So when I came, probably I will tell this part of history. From my training, I had to establish a functional dialysis unit, which was doing both peritoneal and hemodialysis, and I did exactly that. I established it as a patient care unit as well as a teaching unit. And I think most of the senior nephrologists here are trained in that unit, which I established. And once I established it, the first people I taught in that unit were dialysis nurses. I trained dialysis nurses. I also trained dialysis technicians. And in training them, I was using my own personal resource because the administration of the hospital and that of the Ministry of Health could not understand my demands of them. When I talked about a dialysis technician, they said we have, what did they use to call them? Medical engineering department. I think there was a medical engineering. So they said if you want that one, you go to medical engineering. But of course they didn't know exactly what dialysis was about. So when I talked about dialysis nurses, they really couldn't understand. When I talked about renal nurses, they couldn't understand. And I faced a lot of problems. Because I enlisted friends, organizations, mainly from abroad, and they brought them into the country, and they carried out training camps for dialysis nurses, training camps for dialysis. And once these nurses were very well trained and they were working, the principle then was to transfer them from there where they were working. I think every 3 months they were being transferred. So they would take that batch away and you would shout yourself hoarse to make these people understand that these were specialized nurses. But I think right now, you are not having this problem because recognition that there's a specialty called renal nursing is in place. So that is how far we have come. Of course, the rest is history. And now you are here. What I am saying is that we are now a team and we have formed a strong team. We have people at the top who have got the capacity to train the lower cadres of nephro care providers. My request of you is to train and train and train more. Reproduce yourselves. Because once you do, we shall have a critical mass to lobby for whatever we need to get the renal service running. And I know we have really lobbied and gotten here. The other thing that I want to highlight here is that each of us as care providers, they have got their strengths and weaknesses. But when we bring these strengths and weaknesses together, we shall together form a strong team. In nephrology here, there's a lot of voluntarism, there's a lot of sacrifice, there's a lot of love that we offer to nephrology. And I would request you, the young ones who are following in our footsteps, to follow this spirit. Let me give an example of the past 2 days. I have a very busy nephro clinic. And that nephro clinic has got a lot of people and the creme de la creme of people in this country. And once I'm not seated in that clinic, there's a lot of noise that comes from all over the place. My phone is buzzing, people are quarreling and saying all sorts of things. But for the past 2 days, I've been coming here at 8 o'clock and attending up to the last session. I don't care about the money I lose. I don't care about how annoyed people become with me. I will explain to them later. But I think we need to do such sacrifices for the sake of developing nephrology in this country. So, when you are elected to leadership positions in this UKF, into the Uganda Renal Nurses Association and other associations that assist us to give renal care. Please give some sacrifice to this service. We are still a young organization, a young practice, but we shall slowly get there. This one I can assure you. We shall slowly get there. The most important thing is each of us to have a legacy, to put a building block on this nation. This is our country, we have nowhere to go. You have seen people chasing us from all over the place, China, Saudi Arabia, Congo, South Sudan, America. But at the end of the day, we shall all come back here. Like I told you before, I now feel comfortable even if I got kidney failure. There's somebody who can take care of me. And we should train the lower cadres, those who are below us, as if we are training our own children, because our own children are actually going to be trained by these cadres. So with this, I think I would like to hand over the mic to Dr. Jagenda. To who? To the Secretary General to continue with this meeting. Thank you very much for listening to me. Keep Nephro burning and alive.
Thank you very much, Dr. Sekasambu, for that.